and the process of savior siblings provides us a way to treat such diseases, genetic diseases, which are terminal and diseases which could not be treated. Now, the main focus of our team would be the sanctity of human life. Most important thing the most important aspect in anything is the human life, be it medical science, be it regulatory authorities or ethical domain. The main focus in anything is human life. Nothing is as important as a human life. The sole purpose of many of our researches, the sole purpose of many of our developments, the sole purpose of many of the scientific advancement is to save human life. Now, Savior Siblings provides us a way in which we can save human lives because there is genetic compatibility between the donor child and the recipient child, and it provides us a way in which fatal diseases like Filoni's anemia could be treated. Now, as Glover puts it, we've got to have a very strong reason to resist the means by which a child's life can be saved. Now, Savior Sibling provides us a way in which children's life can be saved. Many of the children who are suffering from fatal diseases who could not be treated otherwise can be saved by this procedure. In any procedure in science, we consider the benefits harm ratio. That is, if the benefits are greater than the harms, then that procedure is adopted. Now, our team's main focus would to convince in the light of human life sanctity, medical treatment progress, and this procedure, which constitutes the future of treatment, that is to treat untreatable diseases and congenital diseases. We would convince that the benefits are much greater than the harms, and this procedure therefore should be adopted. Now, our team would focus on the
Thank you, Farhan. Please proceed. And reminder for all the speakers that we'll be taking strict care of time and stopping the microphone
Okay.
at the conclusion of time and sentence.
Okay, thank you. Now I would like to invite introductory speaker from Team B. She will be Fatma Mariam Muzammal. Please, your time starts now.
Savior siblings are not heroic saviors. Instead, they are experimental pieces created for the welfare of the sick sibling. A very warm welcome to one and all present here. This house believes in the fact that the idea of savior siblings should not be advocated for. We are of the opinion that bringing children into the world just because they have an ideal genetic makeup promotes the idea that children are merely commodities, their existence contingent on their ability to save the life of a sibling. Various parts of the body, like cells, blood, bone marrow, and organs, are continuously harvested as and when required for the sick sibling. These procedures on the savior sibling are not just unnecessary, but also painful and harmful. In addition to this, numerous studies prove that the creation of savior siblings involves three unfortunate aspects. One being the procedure itself, which is based on the idea of selecting one embryo while destroying other embryos, which means destroying potential life. If we do go ahead with this procedure, what makes you think that this will not lead to parents choosing designer babies? Second is the harm on the savior siblings in terms of the physical harm of the procedure and the emotional harm on their mental health. The third major problem is the lack of federal regulations in most countries to protect the autonomy of these savior siblings. As we continue to move forward in this technological world, let us aim to uphold the Hippocratic oath we took and abstain from doing harm. Because if not us, who will save the savior siblings? Thank you.
Okay, well done. Now I would like to invite the first affirmative from Team A, that is Marush Fatma. Your time starts now.
Okay, am I audible?
Yes, please.
So my line of argument is savior siblings is the new future of treatment as it has more benefits than risks. I should prove this point by drawing a comparison between possible risks and benefits. First, we are saving the life of a child from miserable death. Second, when the donor is sibling, there is easy tissue matching as siblings are genetically close. It is more feasible, less chances of graft versus host disease. Rate of infection, treatment-related mortality, chances of transplant rejection are all lower, plus survival rate is higher. Third, psychological benefits, which includes the sense of pride that she has helped a person and contributed to the society by inculcating a selfless approach, ease in social acceptance, and have served a purpose. Possible risks are also there. The procedure of transplant, which includes the risk of anesthesia, which is the greatest risk, lumbar region stiffness, additional blood transfusions, wound infection, and so on through due to intubation. In case of organ transplant, the donor will live a compromised life. The question arises, are these facts sufficient enough to justify the banning of savior siblings? On one hand, there is a life at stake, and on the other hand, there is another life exposed to these dangers which can be tackled and do exist in any routine operation as well. If it is a last resort to save a life with minimized risks, we believe it should be opted. Another question, will savior sibling have a happy life or not after being exposed to a danger? Basically, we are here trying to connect the happiness with physical or psychological illness or disability. If we believe, and we should, that there are people who have faced extraordinary circumstances, unfavorable conditions, does it mean that their lives aren't worth living or they shouldn't be happy? No. There are many examples of such personalities living a far more happy and successful life. Based on this, we believe savior siblings born with a noble purpose will live a far better life. Moreover, the harm done to the recipient will be more. That is the loss of life. The ethical stance of PGD and the consent of donor. First, PGD has a therapeutic objective here. Second, the use of PGD for all other purposes, that is screening for a variety of genetic disorders, has been widely accepted. Hence, just saying that it is unethical isn't a reason strong enough to oppose savior siblings. B. The substitution of siblings' consent complies with best interest criteria, common to cases of consent substitution with those who are legally incompetent. If we trust parents to take future determining decisions of a child, we should also trust them for consent too. Even if there's any exception of violation of child's interest, then we have regulatory bodies and child protection laws to monitor this all. Hence, as the net benefit is far more than the risk, we believe that yes, savior siblings is the new feature of treatment. Yes, savior siblings should be allowed.
Okay, thank you very much. I would like to invite the first negative from Team B, Mr. Rahab Farouk, for cross examination, and that would be 2.5 minutes.
Am I audible? Is my voice
Yes,
clear?
Yes,
Okay.
please go on.
So thank you, Marish, for this speech. However, I question you that the only interest that you have mentioned of is the life of the sibling that is sick. But what about the life of the savior sibling? Are you calling the savior sibling life and the savior sibling health less important? And on what basis do you make this claim?
So we aren't calling the life of a savior sibling less important or less required. What was the main reason that the savior sibling was brought in this world? The main reason for his existence was to save a life. And moreover, we would be considering the savior sibling as a commodity if we discard the child afterwards. We aren't discarding the child afterwards. The child is going to live a normal life, and a life that will be regulated by regulatory bodies to make sure that the child won't suffer from psychological and mental effects. No, we aren't treating the child as a commodity. We are treating both of the children as human beings, and we believe that the child won't suffer from physical or psychological effects, as the child is going to live a life full of pride, a life that he has served a purpose, a life that he has helped a person.
Marish, you keep on bringing up the idea about the savior sibling living a life of pride. Just because you assume that he will be proud of what he did doesn't necessarily mean that the savior sibling is satisfied. What you are putting forward is hypothetical examples. Can you prove one evidence that shows that savior siblings are actually satisfied with the task that they are being given? By the statement that you made that they are born to serve a purpose, you have exactly proved our point. In fact, the savior sibling is not being born for a human being. He's not being born for who he is. Rather, he's being born as a purpose. He has a purpose when he's coming into this world, and this is exactly where we are objecting.
We all come to the world for a purpose. There are people who spend their whole life searching for the purpose, for what purpose they are born. Here the child is given a purpose before coming to the world. He isn't going to face identity crisis. He isn't going to face the the backlash by the society. Rather, he has already earned a name. He won't have a trouble in the social survival. Rather, he will be accepted. Rather, he has earned the favorism of the parents. So we believe that yes, that the savior sibling should be allowed. The savior sibling won't be facing these problems. And the question from my side, in case a patient with such a terminal disease, if not the savior siblings, then what is alternative opposition has to offer? Yes?
Please do it in your part. Now I would like, the time is over. Now I would like to invite the first negative from Team B, Ms. Rehab Farouk, for her speech, please. The time starts now.
Every one of us today was born to be loved for who we are. So I ask the opposition, why is it fair that savior siblings are born for what they have to give and not for who they are? Honorable judges and dear audience, don't let the opposition's emotional dialogues and melodramatic stance on saving lives deceive you. Because in the process of saving one life, they are destructing and destroying so many potential lives. The procedure behind savior siblings relies mainly on IVF, PGD, and HLA to ensure the creation of the perfectly matching embryo to be implanted. Numerous embryos are destroyed simply because we are focusing on having a perfect donor, not just a healthy one. I leave this to your conscience. Isn't this an act of dehumanization? Aren't we mere humans making an attempt at playing God? Hence, my first point. Embryos destroyed in this procedure are worthy of a moral respect sufficient to render the procedure unethical. Assuming we approve the idea of savior siblings and continue with this procedure, one pressing question remains. What guarantee does the opposition team have that this violation of ethics would even work? This brings about my second point. Savior siblings is an uncertain procedure whose sufficient success rate hasn't been determined. Both the ways of conceiving savior siblings by natural methods and IVF have proven to be unsuccessful. This can be seen in the case of the Zamet family who conceived naturally, the Hashimis who undertook IVF and were faced with unsuccessful attempts. These examples lead to the realization that savior siblings is a concept that mirrors gambling, taking a high risk in the hopes that your chance was successful. Once again, I question you. Is the sacrifice of ethics for the sake of an unsuccessful procedure logical? I will conclude by putting forth the GCC plus BC framework. There are two international laws that assess any ethical procedure. I quote the law that says, do not kill, do not cause, do not disable, do not deprive of freedom, obey the law and do your duty. Honorable judges, the opposition is already violating 8 of these laws in their stance for savior siblings. I leave it to you and to the audience to judge that can the violator of law establish benefit or deliver justice to any of the sides involved in this case. Thank you.
Okay, thank you very much, Ms. Rehab Farouk, for your speech. Now I would like to call the first affirmative from Team A, Ms. Maroush Fatma, for cross-examination.
So my question from the opposition is, how can you justify the ethical basis of PGD for other screening purposes, but not for savior siblings? So you are saying that destroying the embryos in the case of savior siblings are wrong, but destroying the embryos in the case of screening for various other genetic diseases is right. I want the first speaker to come and justify this.
Can the cross-examiner give one example of a situation where PGD is being used other than savior siblings?
For example, in the we are going to come from the side to the abortion law. For example, where the embryos are discarded in the case when the child when the prenatal child is diagnosed with some serious illness, or when there is risk to the mother health of the mother, we are destroying the embryo, we are aborting. It is justified in that case, but here when we are saving a life, it isn't justified.
Morish, you have answered your question by your own self. You said when it is a harm to the life of the mother. You have in fact answered your question by your own statement. I think there is no more need to elaborate on this.
Well, the second question from my side is, in the case of a patient with a terminal ill disease, if we don't have any other option available, if not savior siblings, then what is the alternative opposition has to offer?
First of all, the topic of our debate today is not discussing a treatment for the patient. Rather, we are discussing the ethics of savior siblings. Dear Morish, if you are interested in the life of the savior sibling, then I think you can go and research that by yourself, because in no means is this the context of our debate. However, for the sake of answering, I will just say that what can justify destroying of one life for the sake of another? I think the humanity is being overlooked. The ethics are being overlooked when we continue insisting that savior siblings is the right choice.
But in our case, it was clear that we aren't destroying a life. In fact, a life is saving another life, and both lives are allowed to live their own life. We aren't discarding the person after he has served a purpose.
So to clarify this, I think maybe you haven't done your research properly, because when we are undertaking the process of IVF and PGD, we are selecting the embryo that is perfectly matched. But what about the hundreds of other embryos that we are discarding because they were not genetically matched? This is exactly where you are destroying lives.
Thank you so
What about
much.
those people who were aborted before even coming to the world? How can you justify?
Thank you very much. Thank you very much for both of you, as your time has exceeded the limit. Now, I would like to invite the team second affirmative from Team A. That would be Abdul Rahman Basra. Your time starts now.
Okay, so I believe that my fellow speaker has made very clear the essence and sanctity of a human life and the need to preserve it. The opposition kept saying that we are destroying lives when using PGD to create savior siblings. But the opposition, probably the opposition hasn't researched well. A lot of people are aborting their children just because they are genetically, they can get diseases when they grow up. Because of inherited diseases, people are aborting their children. Or in case a Down syndrome is detected during the prenatal, whatever the X-rays they do, people are aborting their children. So I believe that our team believes in the sanctity and essence of human life. The argument I am presenting is the meaningfulness and sense of fulfillment that a savior sibling enjoys, apart from another couple of benefits. The child who is born will have a purpose in life without him having to look for it. As human beings, we all tend to believe that we are born to fulfill our destiny. And the idea of being helpful to someone brings us joy. So a child who is born to save an existing life won't have to go through an identity crisis or harsh experiences before he figures out what he's supposed to do. In this constantly advancing era of technology, each and every human being is in a constant search of deeper meaning in his life, a sense of contribution for which he works his entire life. This child will be blessed from this feeling right from the start. His effort will be applauded and his purpose and contribution written out for him. Not only will he be finding something to do in his own life, this person will be saving and giving life to another person and literally keeping him alive. This feeling blesses him with a purpose that will provide a baseline level of fulfillment, and then he can go on and decide to live his own life the way he wants. On the contrary, as opposition speaks, parents can decide to have, as the motion of the debate is, savior siblings, yes or no. So if we go with no, if parents decide to have a child through normal conception who, let us say, cannot donate his cells to his sibling because they don't match, on realizing that he couldn't help his terminally ill brother or sister, he may become depressed and hopeless for the rest of his life. So I don't see any reason why we shouldn't go for the huge scientific breakthrough that is savior siblings and bring into use the new future of treatment when we can. Besides, a savior sibling will be born without any monogenic disorder, and so the chances of the disease passing on to the next generation will be far more less. As for the
And please proceed.
The
Okay.
voice is gone.
Now I would like to invite the from team B, the negative, the Lina Khayati, for cross-examination.
Hello. So firstly, for Abdul Rahman, I just want to start by saying it seems that the opposition has confused the two terms abortion and PGD. Abortion is done during pregnancy, while PGD is done pre-pregnancy, i.e. picking the right ideal embryo for the process of save your sibling, for saving the life that you stand for and support. Secondly, I would like to ask the opposition, is the opposition suggesting that as parents, or do we have the right to impose or place on others the purpose that they have to, by which they have to live their lives? Who are we to make the decision on behalf of these individuals that from birth you were destined to, for example, donate a kidney, and no matter whether you like it or you don't, you will have to donate that kidney because that is your purpose? Could you please answer that? Secondly, I would also like to ask whether the opposition has any statistics with regards to the actual number of individuals that are quote unquote satisfied or sort of happy once they donate and they fulfill quote unquote their purpose as savior siblings.
Hello, Abdul Rahman, can you hear? Can you please answer?
I think he is disconnected.
Durman, please unmute yourself.
yes,
Abdul Rahman,
we believe
please answer the question.
yes, we believe that there are several other things in medical science and research, several discoveries. For example, we take human cloning. Human cloning hasn't been performed yet. So everything in science needs a regulating body, a law forming agency. If there are proper rules and regulations, we can use savior siblings to save a lot of lives. And if opposition doesn't use savior siblings, then what should we do? We should let those people die, just keep the cure from them. And according to the bioethics, we have a principal bioethic to, as a physician, not to keep a cure from a terminally ill patient. Secondly, the opposition kept saying that we believe that abortion and PGD are same things. Let me tell you that killing a life, taking away a life, whether it is in the form of PGD, whether you are discarding embryos or killing a fetus is much more inhumane to me than discarding an embryo, because an embryo hasn't been planted yet.
Thank you very much.
Whether it is killing a life in PGD or killing a life through abortion, it is killing.
Okay, thank you very much. And now I would like to invite the second negative from Team B, Miss Lina Khayati. You have 3 minutes. Please, your time starts now.
I will remember that I do not treat a fever chart, a cancer's growth, but a sick human being whose illness may affect the person's family and economic stability. Does this sound familiar? It is the Hippocratic oath that each one of us vowed to honor on the first day of medical school. So I implore you the audience, to ask yourselves, who did you make this promise to? The parent, the sick child, or the savior sibling? In the case of savior siblings, a difficult dilemma seems to appear: a sick child's life or the savior sibling's rights. Today, I stand here advocating for the right of the savior sibling, the element whose physical, emotional, and psychological rights are constantly being undermined in this conflict. I will begin by exploring the physical harm inflicted upon the savior child, who, to remind the audience, is a healthy child with a healthy body and the potential to lead a healthy life. Bone marrow can be extracted from the savior siblings. Not only is this process painful, but evidence suggests that it can have effects such as fatigue, pain at the site of extraction, headaches, sleep problems, and less commonly bleeding in studies done in 2016. In addition, hematopoietic stem cells can be extracted from savior siblings, a process which includes the administration of cytokines, namely GCSF, to induce proliferation of hematopoietic stem cells, leaving the donors at risk of myalgia, arthralgia, and more serious adverse events such as splenic pain and rupture. Moreover, they can also be used for the purpose of umbilical cord donation, which, according to a study done by Cochrane collaboration, found that the delayed cord clamping has therapeutic effects of decreasing the chance of anemia, whilst in this case we aim to have earliest possible removal of the cord, hence placing the savior sibling at risk for anemia. Harm done is not only limited to the sibling's physical body, rather it also encompasses his or her emotional and psychological well-being. In 2004, Wendy Pacman's study revealed that approximately 1/3 of all siblings affected by the sibling donor process were afflicted with moderate to severe PTSD, post-traumatic stress disorder. In addition to the physical harm implicated by the hematopoietic stem cell donation explored previously, a study done by the University of Calgary found that almost all of the study's participants felt that they had no choice but to donate to their siblings, while some felt that they were coerced or bribed into it by their families. Furthermore, in cases where these transplants or donations are unsuccessful, the Washington and Lee Journal of Civil Rights and Social Justice in 2018 noted that negative feelings of anger, guilt, and blame were present. The same emotions were also found in donors who were uninformed and potential medical complications or did not receive adequate support afterwards. I rest my case with a quote from Bernard Morin, who said, "We realize that it's done with the best of intentions, but at the end of the day, you're cannibalizing a little human person who has no say in the matter. I'm afraid I have to object to that." Thank you.
Thank you so much, Ms. Lina Khiati. Now, I would like to invite Mr. Abdul Rahman, second affirmative for cross-examination. And your time is 2.5 minutes. Please start.
Okay, so first of all, I would like to make very much clear that medical ethics have always been ever evolving. So we cannot just stick to an existing set of rules. We cannot stick to the past. We have to move on to the future. This debate has merely been a balance between risks and benefits. And we have no need to prove that to all the great doctors present here today that the benefits greatly outweigh the harms. Now, my question from the opposition is, don't you think the consequences of allowing the treatment to severe siblings are far less terrible than a fraction of young people dying with terminally ill diseases just because we let them die even though we had a cure?
Okay, so it seems this is a point that the opposition likes to hold on to very much, which is the idea that with the savior siblings, we are quote unquote saving a life. Firstly, you cannot guarantee that after the donation is done, that the patient or the sick child will continue to live. Many cases they do die. Okay, so unless you have a statistic showing that they continue to survive healthy without any sort of complications or relapse of leukemia, for example, I'm afraid your point isn't as valid. Secondly, I would like to also clarify that when you are taking that savior child, that savior sibling, is healthy. They have they don't have any sort of physical or emotional or mental distress or disease. They are healthy, and they were picked that way via PGD, right? And so when you take that healthy child and you take away their bone marrow or hematopoietic stem cells, whichever one you wish to take, or organ, kidney, whichever, you are making them, you're taking them from healthy children into diseased children, or children that are less healthy than before, that now have to have regular visits to the hospital, that have emotional and psychological consequences, as I
Listen.
mentioned earlier.
Please.
it's funny how I'm reading all your arguments on the Wikipedia page of savior siblings, and risks exist in every type of transplant or whatever you say. So
Uh,
the savior
okay,
siblings
sorry.
treatment through savior siblings hasn't been allowed yet. It is only legal in the UK. It hasn't been allowed
First,
yet, so we cannot form a proper ratio. We cannot present statistics as far as the few cases that have been performed yet. 90% of them have been successful, and there has been no record of any long-term health effects in the savior sibling.
firstly,
So
your
my
use of
next
Wikipedia as a
Please,
sort
please,
of,
please, please,
evidence point is
I
applauding.
would like to say, Miss Lina, be brief because you both have exceeded your time already.
Oh, sorry. Oh, sorry, you want me to be brief? Oh, sorry, I'll be very quick. Yeah, as I said, the Wikipedia page is appalling. Secondly, again, you cannot compare child donors to adult donors. Adult donors give consent, children do not, therefore they are not equal, so your argument is not valid. Okay, thank you.
Thank you very much, both of you. Now I would like to invite the third affirmative from Team A, Mr. Hasnan Mushtaq. Your time starts now.
Am I audible?
Yes, please go on.
Okay. So as conventional people and fundamentalists, we have always opposed any new advancement in science. Look, medical ethics are a set of rules which are predetermined for already existing procedures. And when we talk about a new procedure, we talk about the ethics regarding that. If you're, whenever we put an argument in front of you, the opposition comes up with the argument that there are harms, there are this harm and that harm. See, when we have to apply a new procedure and make it sure that goes on in the future, we have to weigh the losses and the benefits and the disadvantages and the advantages. We have made clear that for the application of this procedure in the future, the motion of the debate clearly states that is the savior sibling future of the medical treatment, and we are saying yes, it is the future of the medical treatment. So when we are saying yes, it is the medical future of the medical treatment, we are coming up with the argument that there are benefits and there are less harms. And when they come up with the argument that that there are several other harms too, there are several other harms for every medical procedure out there. So you do not stop adopting them or using them for the treatment of the patients. And there is literally never 100% surety that a procedure will be successful. Even a surgery, even in a surgery, you cannot say that it will be 100% successful. So I cannot get what they are trying to say when they come up with the point that there is no surety in it. Now my positive case will be regarding the psychological issues. The psychological issues are far less in the case of savior siblings. Literally, this argument has been used for years, and they still will use it because it is there on the Wikipedia page. But there is no substantial evidence in it. We have three viewpoints for considering the psychological issues. First are the parents. It has been seen that parents show increased affection and love when they have multiple children because they feel greater responsibility and they try to balance love for all the siblings. They see. We are conceiving it as a natural baby. We are just selecting it. We are just selecting the embryo so that his genetic makeup matches to the sixth sibling, so he has an additional benefit. And the benefit of the savior sibling will be that he will be free of the genetic disease to which he might have been a potential carrier, of which he will be a carrier. So there are three viewpoints. The parents will show increased love. Even if we do not consider this argument and go with the argument that parents pick favorites, it is still unlikely that parents will not love the savior kid. The reasons being that firstly, he saved the favorite kid. And secondly, he shares the same relation with the parents as the other sibling. It is evident that in accordance to the favoritism, parents will also value the savior sibling. The second viewpoint will be of the savior who has a sense of belonging now.
Thank you very much, Mr. Hasnan. Now I would like to ask this third negative, Ms. Tarab Iqbal, for cross-examination, and your time is 2.5. I would like to request to both of you, please brief with your be as brief as possible with your questions so the next person can answer. Thank you.
All right, thank you. So I would like to first ask the question in a yes or no manner. Do they agree that benefits should outweigh the harm? Yes or no?
Mr. Snan, please unmute yourself.
Yes, we do agree that benefits
Okay.
should outweigh the harms.
Then, are you not aware of the research that was published in 2015 that proved that the success rate of savior sibling, especially in Fanconi anemia, was determined to be only 5%? You are talking about a surgery, you are talking about a procedure. When we implement it in medicine, we at least have a criteria for it to have substantial amount of success for us to implement it. A 5% success rate, is that what you're advocating today?
All right. Okay. Uh, I hope that you are aware of the probability rule. This particular research you're talking about wasn't formulated after performing the procedures and then calculating the results. It was just a probability basis. And still, I believe that if there is a 5% chance of saving a kid, it should be implemented, considering that there are far less health hazards and psychological issues to the savior sibling. So even if there is 5% ratio in the case, if we ban the savior sibling procedure, there will be 0% a chance of survival of that sick sibling. So I think that yes, 5% of the chance of the survival of sick sibling is still morally allowable.
Then I think you are contradicting your own point about benefits outweighing the harm, because the benefit in this case is only 5%, whereas the harm can be determined up to 95%. I think you have contradicted yourself.
All right. What exactly is the harm in that 95% of the cases? That savior sibling is donating stem cells, and the sick sibling does not feel better or does not gets better, and he even dies. So what exactly are the harms you are trying to point here out?
Yes, I will explain
is
that.
there any please listen to me, is there any health risk to the savior sibling if the sick sibling dies, or is there any health hazard to the sick sibling because of the transfusion of that savior sibling?
I think
What
when we are
exact
talking
health risks
about,
are there?
I think when we are talking about the 95% harm, we are talking about how the procedure in itself has a 95% probability that it is not going to work. As far
Okay.
as harms,
Thank you very much, both of you. Now I would like to invite the third negative from Team B, Ms. Tara Bikwal, for her speech. You have 3 minutes. Your time starts now.
it has been rightly said, while medicine heals the body, clergy the soul, law and ethics heal the societal rifts. A very warm welcome to all. Let me begin by asking a question. Would the conscience of any doctor allow for them to prescribe a medicine, a device, or even a procedure that has no regulations on it, knowing very well that tomorrow their patient can get into a spiral of ethico-legal predicaments besides the medical ones? I would like to inform our audience today that until now, out of 200 plus countries of the world, a mere 9 or 10 have regulated the topic of savior sibling. Even in these countries, laws fail to explain so many things. Firstly, the laws fail to address what constitutionally protected right does a minor savior sibling has. The authority of consent lies in the hands of parent. However, proxy consent is only granted to a parent so that they can make decisions that are beneficial to the child or the intent of the procedure is therapeutic to the child. Key words being beneficial and therapeutic. However, both of these criteria get violated in the idea of savior sibling, wherein there is no beneficence or therapeutic outcome to the healthy donor. In fact, he or she may be even subjected to significant physical and psychological harm, as already discussed by my colleagues. Logically, it is probably not very important that we obtain a newborn's consent to use their umbilical cord, which is traditionally discarded. But what if the procedure involves significant pain or a potentially lifelong alteration? It becomes very important for the child to consent. or to understand what happens to him or her? Are we waiting for the day the child grows into an adult and files a lawsuit against decreased quality of life and lack of consent? What provisions of law are we equipped to deal with this? Furthermore, what about cases in which there is going to be intrafamilial disagreement, as was the case in which 3-year-old twins who were going to make donation for their 12-year-old stepbrother who was suffering from leukemia? The mother of the twins, Nancy Curran, declined the consent, whereas the father authorized it. How equipped is our judicial system to deal with cases like these? I'd like to end by saying the famous words of KJ Kellner. Some of the worst medical atrocities to date have been rationalized with the notion that there is something wonderful to achieve and that there is no other way to achieve it. We need to be careful lest misguided compassion moves us to pursue a quick fix that will foster a thinking that will harm a much larger number in the long run. Thank you.
Okay, thank you very much, Ms. Sarah Iqbal. Now your speech will be cross-examined by Mr. Hasnan Mushtaq for 2.5 minutes. Your time starts now.
I have two questions for you. When we bring a normal child into the world, we do not ask him or her that he wants to be born or she wants to be born or not. So I do not agree with your point that bringing a child into this world is even moral, because if you see that the poverty is rampant, so if you cannot secure a future for the child, it is even immoral for him to born in any family. So basically, this debate shifts towards the existentialism. If you bring the argument that the consent should be taken from that very child who has to born now.
I think
And my
there's a
second question will
difference.
be if there is a lack of regulation, should we discard that procedure at all? There was a time when there were no laws about theft, or there was no laws about robbery. So is there a need to strengthen the regulations, like in the 10 countries you yourself said that have allowed this procedure? So is there a need to strengthen the regulations regarding this procedure, or we should discard it?
Okay, so the 2 points that you made, first of all, about the consent, I think you have misunderstood. I'm talking about the consent of the child to undergo the procedure, not the consent of the child to be born or not. There's a difference, because in adult, if you talk about organ donation, if you talk about hematopoietic cell transplantation, in all of these procedures, there's always the consent of the adult. That means adults consent to performing that procedure. In the case of a child cannot do that, which is why this procedure becomes unethical. Because tomorrow, as I said, if the child were to grow up and were to file a lawsuit, what law or how are we going to approach, or how are we going to solve this problem? To answer your second question about
Regarding this, I need to extend that medical ethics or even ethics are ever evolving. See, if I file a suit against my parents that I never wanted to be born in this world because it is not livable anymore, so who will be responsible for that? I'm talking
I
about
don't
this issue.
I absolutely understand, but I don't think our issue is about being born in this world and whether we want to be born in this world or not. I think the issue at the hand is the consent of the child to undergo the procedure, correct?
Okay, thank you very much, both of you, for this wonderful debate session. Now we will move towards the rapid fire round. This round will be having two participants from each team. The affirmative side will have Ms. Marush Fatma and Mr. Hasnan Mushtaq, and the negative side will have Ms. Rehab Farooq and Ms. Tarab Iqbal. Your time is for rapid fire round is 10 minutes and time starts now.
Okay, so I would like to begin the rapid fire round by saying that the other team constantly says that this procedure is a very recent one. and we do not have substantial information. They moreover hide behind accusing us of using Wikipedia when they do not even understand that this procedure has actually started since the early 2000s. We have hundreds of cases of parents that have applied for savior siblings, while so many have failed and a few have been successful. So to keep on bringing up Wikipedia and hiding behind that is just proving that you have not researched. And the fact that you brought up Wikipedia and you say that we have caught it off Wikipedia means that you have as well opened Wikipedia and checked out the site, which is why you quote unquote that we have been checking it.
Obviously, we are opposing the opposition on the same grounds as you guys are. So the third speaker comes up with the points of the ethics and again the benefits and the risks that outweighing the thing, which has already been tackled in my point, which proves that they weren't even listening to the whole thing properly. So my question to them is what they were bragging about the whole thing of the consent. Even in the case of legally incompetent person, we trust a guardian for the consent. Here, a child who is too immature to decide for himself. Why can't we trust the patient? Why can't we trust the parents for this decision as well? And the second thing that they kept on bragging about was the harms, was the risk. Yes, we do believe that there are harms. There are harms in every medical procedures. There are harms in every medical treatment. Does it mean that we are going to ban every treatment? Even when there is the slightest chance to save a person, the doctor are willing to take the risk as long as there is consent. Here we have the consent. Here we have the consent of a legal person. That is the parent of the child. And even in the cases where their parents are not incompetent, we also have the rules to tackle this. In UK, it is required that the clinic has a license to perform this procedure. Similarly, HFEA allows testing and tissues matching under strict criteria. Even the case can be taken to the court in US. We have regulatory bodies to regulate this. So I want to ask the proposition that how are you guys going to defend the point of the consent now, and how are you guys going to defend the point of the benefits and the risks now when it already had been tackled twice from our side?
Okay, Marish, so let's ask your parents to kidnap you today, take you and take your kidney from you and be like, well, it's the parents' choice. They have the consent. So would you agree to this? Would you agree to your parents taking your kidney without asking you? And I'm definite your answer will be a no. And the same goes for these savior siblings. We are stealing the things from them. They have never allowed to take their bone marrow, to take blood transfusions from them, hematopoietic cells, organ donations. When you do not agree for your parents to do the same for you without taking your consent, how can you go on saying that parents are the ones that are in right for a consent? This is not like a parent telling a kid to brush his teeth or to go to school. In that case, I would agree it's the parents' choice because they have the best interests at heart. But this is about the child's right to his body, about the child's right to every single thing that is within him. And no parent, no organization, no law, no country can steal this right from the parent. And I believe this topic of consent should just end here and there, and we should move on to discussing further issues because this is reaching nowhere.
Oh, my dear opposition, I have already cleared that there are regulatory bodies to regulate in the case of if the parents keep on stealing, what you call donating as stealing, if they keep on stealing from the poor donors. So we have regulatory bodies to regulate this thing. And you have already opposed your own point by saying that we trust the parents to take some decisions. Yes, we are trusting the parents to take some decisions. When a child is sick, the child isn't able to give a consent. For example, a child at an early age is about to go through a major heart operation. So if we are going to wait for a child to mature enough, we are going to wait for a child to mature enough or not.
But I think our opposition fails to understand what we are talking. I think we're talking about what you are comparing is a beneficial procedure. We're talking, if you talk about the consent of parent to allow for the child to undergo a treatment or a surgery, absolutely, we agree with you. But here we're talking about letting them undergo, a perfectly healthy child to undergo an organ donation. And as you talk about regulation, now let me tell you, the fact of the matter is As of now, only 9 or 10 countries have regulated, as I said, out of 250 plus countries of the world. Does it seem to you that this is a justified argument from your end to say that the procedure is regulated?
Here you fail to understand that the parents are not going to carry out the procedure on their own. They have to go to a registered clinic. They have to ask the regulatory bodies, as you yourself say that a lot of people have applied for the savior sibling procedure and many of them were rejected. So that exactly is the case. Many of them will be rejected because they will ask for it out of nothing. There will be no benefit. So that exactly is the regulation what we are talking about, that we
So
are
are you
allowing
suggest
only those
so are you
we are only allowing those parents to carry this procedure out if they are not doing anything immoral or anything hazardous to the savior sibling, or anything that may exceed the capacity of that savior sibling to donate.
But they are harming the savior sibling. The savior sibling, when you take a bone marrow donation out of him, he is subjected to number one, the pain of extraction. Number two, the entire prolonged hospital stay that he has to go through. When he is a healthy child with a healthy body, he can live a normal life while he has to be forced into long chronic hospitalizations for the sake of a sake of a sick child. But what is his fault in this? He was born healthy.
All right,
Why?
all
What
right.
justifies the fact? Moreover, I go on to please let me complete. I go on to
So now you
explaining
have agreed that we have to outweigh the losses and the benefits
I
of
am
this procedure.
speaking. I'm
That's
sorry,
right.
Hussein Mustaq, but you are cutting in my point, and that is not one of the rules of the debate. When one speaker is speaking, please allow that speaker to continue first of all. As I was saying, that even with umbilical coordination, the child is subjected to a chance of anemia. With bone marrow, he is subjected to chance of arthralgia, myalgia, pulmonary embolism. With the hematopoietic stem cell transfer, he is subjected to to many such chronic complications like nausea, vomiting, headache, lifelong disabilities. So you are saying that he is subjected to no harm when it is scientifically proven through studies that this child is not only subjected to physical but also to psychological harm.
All right, I have two answers for this. Uh, yeah. First of all, when you are saying that there are health hazards, there are the pain that comes with it, the procedure. Tell me in a yes or no manner that when we make a transplant, or when we do bone marrow transplant from one donor to a recipient, are there any complications in that procedure too, or is
yes.
that
Yes,
safe?
there are complications.
There are, exactly, there are. So we allow that procedure to go on because we know that there may be a minor chance of the survival of the patient. The problem
No,
here is the consent of the child. Exactly. The
yes,
Exactly
problem is
what you
because
said.
that child,
You had said,
that adult can
is the.
agree. That adult can
Can you
give his
please listen to
consent.
me now? Can you please listen to me now?
Okay, okay,
Problem
go
here
ahead, go ahead.
is that of the consent. When you're an adult, you can consent to that procedure. And secondly, uh, there are regulatory bodies, as I've already pointed out. What are the regulatory bodies there for? They have to formulate the ethics of this procedure. We are not talking about what ethics or what limitations should be there.
Okay,
That is the job of a regulatory authority. We are pointing here out that regulatory authorities should be strengthened, and this procedure should be allowed in the light of that authority, that regulatory authority.
okay,
okay,
so
let
let
me
me
tell you
ask you
what
a question.
okay, sorry, Tarab, go ahead.
All right, let me ask you a question, valued opponent. So now, should there be a conflict of interest between an ethical issue and a medical issue? I will give you a case of Whitaker family from the UK. So basically,
Please,
they applied
Mr.
for
Naeema,
savior
you
sibling.
have only 20 seconds left. You have only 20 seconds left. Please be brief.
All right. So, my question to you is if there's going to be a conflict of interest between the ethical aspect and the medical aspect of savior sibling, what would you as a team choose?
We believe that depriving a child of life is more unethical. This is we believe as a team.
Kumaris, I have to add in here that you guys kept on talking about regulatory bodies. Since you want to depend on regulatory bodies, then let's bring them in. Number one, the first regulatory body is the GCC, the Global Code of Conduct of Ethics. Number two, the B plus C framework. Both of them state, do not kill, do not cause pain, do not violate autonomy, and respect everyone's decision. And right now, you, with your stance for save your siblings, you are violating.
My dear opposition, we are talking about the ethics as well as the we are talking about the ethics as well as the medical approach. And I have already stated the regulatory bodies in this case, in the case of save your siblings.
Okay, thank you very much, both of you. Thank you very much. Now I would like to invite the concluding remarks from Team A, Mr. Zain Tariq. You have 2 minutes for this. Please, your time starts now.
Our team has beautifully explained that the benefits of this procedure have greatly outnumbered the risks. First of all, it has the benefit of saving a human life with little risks. Then the team opposition pointed out that the parents would treat the savior sibling as less important child because he was born to save the other. Now, this was beautifully answered by our team that the parents will have greater affection for that child, or in that case, we can say equal affection for both the children because he was born for the purpose of saving the other child. So this would lead to greater affection for him. He will not be treated like a commodity. He was born for a noble purpose. Team opposition then put forward that he's being born for a purpose. So why is that bad? His purpose of coming into this life was noble. I don't think there is any harm in this. Then there was a question that destruction of embryos is unethical. Team opposition has hypocritically said that abortion laws are well. In case of abortion, you kill the fetus, while in this procedure, you are killing embryos. So they were supporting abortion and they were resisting the procedure of savior siblings. I couldn't understand any of that. Then they hypothetically just said that it is an uncertain procedure. However, there is no such thing. There is a far greater match of the donor and recipient tissues. HLA antigens have a greater match. There are greater chances that this procedure will be successful and life can be saved. They were absurdly unable to answer any alternative for treating such diseases except savior siblings. Opposition pointed out that there may be physical harms to the savior siblings. Now this was beautifully answered by the team proposition that in any medical science we consider benefits and risk ratio, and in the case of savior siblings the benefits are far more greater than the risk. We cannot resist such a
Okay, thank you very much, Mr. Zain Tariq, for your concluding remarks. Now, for concluding remarks from Team B, I would like to invite Ms. Fatma Mariam Muzammil. Your time starts now.
The procedure of savior siblings has the potential to commodify or harm the child to be born in ways we have discussed in our debate today. The opposition team keeps talking about the abortion laws when today's topic of discussion has been savior siblings. They ask us to provide alternative treatments when we are sitting here to discuss whether the idea of savior siblings is ethical or not. I would like to re-establish that savior siblings are unethical, with the main reason being that the welfare and the rights of the savior sibling are not taken into any consideration. They lack autonomy over their own body and are constantly asked to provide for the sick child, irrespective of its implications on their own health. This leads me on to my next point, which is that savior siblings are not to be treated as means to achieve organs out from, and instead have a life of their own, which they have the rights to live and fulfill their own dreams. The opposite team talks about the purpose of their life being to donate organs, and I would like to tell them that the purpose of any child's life, we cannot tell them what their purpose of life should be. It is what that child wants, and the rights of that child are not being taken into consideration. Another point we have to consider is the potential psychological issues that the savior sibling may face throughout their life. We live in a world where in the 2020, we are talking about mental health, and you are telling that there is no big deal about psychological harm on the savior sibling's life. What if they are depressed and end up committing suicide? Who will be responsible for that then? Lastly, as medical professionals, I would urge each one of you to consciously choose not to advocate for the idea of savior siblings, as it is not just unethical, but also harmful to the savior siblings at multiple and numerous levels. Let us ask ourselves, what rights do we as individuals have to give false hope to a family of complete cure when that may not even be possible? Thank you.
Thank you very much, Ms. Fatma Mariam. This is all from the session one. Thank you very much, all the participants. Now I would like to invite the chair of the session, Dr. Naeema Al-Gasseer, to please give her concluding and remarks and sum up the session. That would be followed by the remarks from co-chair, that is Dr. Mariam Moti.
So impressed with the both teams. The topic chosen is a very, very critical topic that address each one of us, our morality, our ethics, our medical practice, our lifestyle, our beliefs, our values, our principles. Both teams, I have to congratulate you, and I have seen in the chat how everybody's congratulating both teams on how this debate has gone. You have both tried to evidence, actually no, you have both brought the evidence. The team opposing brought much more robust evidence. The team of A, at some points, they have done excellent job, but at some points it seems through this vibe of technology that they could have done a better statement together. Team B came very forceful, and it showed that they have communicated even during the session, sometimes too pushy. However, came back very well with their arguments. Team A, rebuttaling, again brought back excellent lessons. Both teams actually focused as much as possible on the ethical angle. Both teams argued about the code of ethics. Team B actually gave a serious one. Three things that I saw that need to be brought up. One thing, the psychosocial, it brought up by the Team B more. The other one, the cultural aspect of where we are, what's happening. The science is far advanced, and both teams had brought the science angle to it. Team B brought much more evidence and demonstrated that they have actually gone into the details of references. Where I see that have been challenged us, who are all the judges sitting around and mentors and panelists, the two of you have done brilliant for the first time addressing a very, very sensitive topic in our societies, addressing an issue of having someone to be brought to treat other. There was not much on the donation, distribution, except talking about the savior child. There were references to the laws and legalities and framework. My role, I was reflecting, and in the region, absolutely, as was mentioned, very few, lately only in 2011-12, we pushed for the research on the human being and how, especially on the donor donation. That was done in terms of the clinical trial. So is this going to be under clinical trial? I will leave it to the team to continue the debates. For the first debate, for a very sensitive topic, both of you have really done very, very well. I want to clap. I know that we are not sitting together, but if we were, you would have now heard clap for Team A, you would have heard clap for Team B, because what you have done were brilliant. I think we are all in mute except me, maybe. I'm seeing some people, Dr. Isham, clapping. I would like us to bring the ethical component of it. Let us continue. This is going to affect L, and I want really that I heard more than once, both teams are talking about the rights to health, the rights to services, and the rights to care. This joint values, how can we reach to a conclusion? I want to stop here and give the floor to the vice chair. I hope that I have captured, I haven't, because it was very rich, extremely rich. And I have to say, make us, each one of us, reflecting on what are our beliefs of pro or against, which is going to continue. I have to say, it's very hard to be sitting here objectively, not looking at the contents detail and only looking at the debate, which are the values of terms of how the passionate, both were passionate, the energy radiated, both were positive, the way the arguments happen, and the respect to each other when we look into the debates, the listening, the tolerance, and the patience. These are values we want to have in debates. These are values we need in this region. And I want really once again to congratulate the organizers, to congratulate universities that joined, to congratulate Agha Khan, because I know that now my former friend and colleague, Dr. Simin Siddiqui, is there. He was the former director, and your minister is also a former colleague who is Dr. Zafar Mirza. We have debated this before, but in a small coconut. Now it's open, and I'm very proud that our youth, the medical students, and the health professionals are taking it forward. Thank you very much.
Thank you, Dr. Mariam. Please give your remarks.
Yeah, I'm so happy to be part of this team. I can't believe it, how well the students have done. I'm a professor of medicine at Loma Linda University and as well as the University of California in Riverside. And I'm impressed. Not too long ago, I was a student like you, trying to shine and reach the stars. And you guys have done it. You've brought up the principle of respect for autonomy. You brought up the principle of non-malfeasance. You brought up the principle of beneficence. You brought up the principle of justice. You've discussed all of the ethics part, the bioethics parts that are important for every day as part of your career. And I am hopeful that you will continue to work on it as time goes along. I think both teams have done a wonderful job. I'm very humbled to be selected as a judge, and I hope to hear from both the groups participating in the debate over the time as it comes along. And I think you have a good grasp of what you are trying to bring up. The debate was excellent. You both paid respect to each other. You brought good topics, good points, and you brought up a good idea that even being far away, not being able to see each other, you can still work online and bring a lot of things together. Research is a good field, and I'm sure as time goes along, you will be helping each other and you will not be fearing anybody. You will grow, and we are here to help you shine in your work. And I hope may the best team win. Thank you.
Thank you, Dr. Mariam. We are moving forward to the second session. Please note there is a separate form for each session to submit the judgment. All the judges who are assigned to the session, please submit your judgment. We will be announcing the result at end of the second session. Thank you. Dr. Rath, now it's your turn. Please take. Thank you, Dr. Farhan, for moderating first session.
Thank you so much. And good luck to everyone.
Thank you. Dr. Rath. Okay.
Thank you. First of all, change, my dear audience, is always brought when a stream of... Excuse me, am I audible?
Yes, please. There is advice. Please.
Am I audible?
Yes, please.
Change, my dear audience, is always brought when a stream of thoughts is channeled through an eloquent voice. Ladies and gentlemen, Assalamu alaikum. I, Ahrar, President Army Medical College Debates and Literary Society, on the behalf of APPNA Merit Organization, welcome you all in the second session of today's competition held between King Edward Medical College and Dubai Medical College. The topic for this session is mental health patients should be treated within the community or outside the community. Whereas mental health, according to World Health Organization, is a state of well-being in which the individual realizes his or her abilities, can cope with all the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. And within the community implies the living environment or the society in which the individual is already living. And outside the community implies taking the person out of his living environment and placing the individual in isolation or among other similar individuals. Now coming to the proceedings of the event. The two teams comprising of 4 participants from each institute will be taking part in this session. 2 minutes will be given to the introductory speakers of both the teams, followed by 3 minutes for the rest of the participants. Apart from the introductory speeches, each speaker will have a 2 minutes and 30-second cross-examination from the respective opposite team member. Speakers are advised to keep in view the time limit provided. Ladies and gentlemen, we are honored to have Dr. Shahid Sharif, who is a consultant clinical oncologist and vice chair of Association of Pakistani Physicians and Surgeons of UK as a chair for this session. Sir will be joined by the co-chair member Batul Al-Muhandis, who is a consultant in nursing policy and education development, Royal College of Surgeons in Ireland Medical University, Bahrain. I would like to thank both of you for taking out time out of your busy schedule and attending this event. Thank you. Ladies and gentlemen, the judges for this session are Dr. Ijaz Ahmed Khan, Associate Professor of Public Health, Health Services Academy, Pakistan, Professor Khatija Qamar, Head of Department of Anatomy, Army Medical College, Dr. Hina Javed, Assistant Professor in Family Medicine, University of Health Sciences, Lahore. And the final judge for this session is Ma'am Suraya Shahnaz, who is from Multan College of Nursing, Pakistan. I would once again thank all the judges for being with us this wonderful afternoon. Thank you. Ladies and gentlemen, with this, we'll proceed with the debating session. The first speaker of this session is Abdullah Saeed from Team A, representing King Edward Medical University. Abdullah, please.
So starting with today's motion, should mentally ill patients be treated within or outside the society? Mental illness comprises disorders characterized by a combination of abnormal thoughts, emotions, behaviors, and relationships with others. They comprise a broad range of problems. For the course of this debate, the very basic forms of illnesses such as depression and anxiety are being excluded. Anything above that falls in the ambit of today's debate. Example, borderline personality disorders, dissociative disorders, psychosis, schizophrenia, epilepsy, etc. They are usually chronic illnesses and are treated over a long span of time. Treatment outside the society means treating the patient in isolated centers and mental asylums during the course of the disease with almost non-existent social interaction or community participation. Treatment within the society means treating the patients at community level without isolating them from the society and their family. It is important to realize that we are not against treatment of mentally ill patients in hospital wards in cases of medical emergency or acute attacks of the disorders. The hospital stays being short-term until the emergency subsides. But admitting them for the entire course of their treatment and isolating them is totally unacceptable. Ladies and gentlemen, statistics have shown that more than 10% of the world's population is mentally ill, these disorders being more common than cancer, diabetes, and heart diseases. Mentally ill patients do not become retarded by their own will. Genetic and socioeconomic conditions are major factors which drag them into the disease. Such people are distinct individuals with their own individuality, integrity, and place in society. They are major stakeholders in this case, and whatever is better for them should be given due importance in making policies for them. Our principle suggests that mental health patients should be treated in a balanced healthcare system within the community in which hospital visits and stays should be short-term, need-based, and only in emergency situations. In all of the scenarios, patients should be provided regular therapeutic sessions, either via mobile phones or counseling by therapists. Such a balanced healthcare system would ensure treatment and care specific to the diagnosis and needs of each individual, which is crucial for the betterment of these patients while keeping them close to their loved ones in the community. As team proposition, we'll walk through the entire case by first telling the disadvantages of treating people outside the society, and my third affirmative speaker will address exactly how treatment within the society can be executed properly in order to
please conclude your speech.
Thank you.
Thank you, Abdullah. Now the first speaker from the team representing Dubai Medical College, Speaker Lubna Latif from Final Year.
Fellow delegates, respected chairs and moderators, my name is Hira Hassan and I will be replacing Dr. Lubna Latif. My team speaks for the motion mental health patients should be treated outside of the community. Now, firstly, I would like to begin by stating what is institutionalized care. Now, according to the Washington State Legislature, it is care provided in a hospital, nursing home, and other facilities which are certified by state, and these are primarily affording diagnostic, therapeutic, and preventive services along with rehabilitative and personal care services. Now, in 2017, 8.5 million Americans adults suffered from both a mental health disorder and a substance use disorder, or co-occurring diseases. Drug abuse and addiction cost American society more than $740 billion annually in lost workplace productivity, healthcare expenses, and crime-related costs. People of the community, or rather our society, conveniently judge people of mental health issues in relation to their genes, to their family problems, violence issues, and whatnot. And now more than ever, in these unprecedented and trying times, we need to explore and implement certain measures to combat this mental health pandemic. My team and I are here to compel you why treatment of the mentally ill should be done outside of the community and should include mental health facilities. And why should we treat patients outside of the community? Firstly, to protect them from the effect of stigma that so negatively affects the prognosis of mental illness and the treacherous nature of the said diseases that results in unwarranted relapses that can affect the patient as well as the surroundings negatively. There's a strong need for tertiary care that provides better equipment and expertise and has a safer environment and a higher level of specialty. I would now like to leave the floor to my teammates to prove to you the superiority of the treatment of mental health illnesses in professional institutional facilities. Thank you.
Thank you, Speaker Lubna. Speakers, do keep in mind that you will be muted if you exceed your designated time. Now, the first affirmative speaker from King Edward Medical University, Faiza Khan, will speak.
Am I audible to everyone?
Yes, go ahead.
Ladies and gentlemen, we live in a world where mental health has always remained a taboo. For more than any other type of illness, mental disorders are subject to negative judgment and stigmatization. We as Team Proposition today believe that misinformation surrounding mental disorders should be dispelled and that each and every individual should be encouraged enough to come forward and address their illnesses more openly. And that we believe is possible only by treating mentally ill patients within the society, not outside it. And how do we make that possible is what our positive case is going to be about today. The first line of argument that we explain to you today is how treating mentally ill patients outside the society instills the idea of being an outcast and how treating them within the society diminishes this idea and promotes social connectedness. I explained this to you on two basic tiers, societal and individual. On societal level, firstly, it instills a sense of reluctance in people to get themselves diagnosed. When we ostracize a certain faction of people for their mental illness, this whole idea of being socially abandoned and rejected makes them reluctant to approach psychiatric help. And instead of becoming more and more open about their problems, they try to conceal it somehow. And the idea of mental health being a stigma and taboo gets promoted. We have specifically seen that happening around us these days. The whole scenario during the COVID pandemic where people were reluctant to get themselves tested, fearing that they would have to be isolated in quarantine centers to their disease. On an individual level, primarily, it hinders the recovery of the individual. We tell you how. First of all, we believe that the main stakeholder in this consumer power is the mentally ill patient himself, and that his freedom of will and right of self-determination are things that need to be respected and conserved because that's what plays a pivotal role in his recovery. We believe that the idea of incarcerating him without his compliance and ostracizing him undermines the say of consumer power and right of self-determination, which we strongly condemn. Secondly, this incarcerated person begins to feel dejected and valued and depressed for being an outcast, which is a barrier in way of his recovery. Now, on a secondary level, even if the individual gets recovered to some extent, his reinculcation within the society as a normal, healthy individual becomes difficult. And again, we tell you how. Firstly, when he has been socially abandoned for so long and returns, he's looked down upon by his peers by being called abnormal or insane, and even if they don't, he finds it extremely difficult to reconnect and relate to them again. Secondly, he lags behind the rest of his peers because his ability to look after himself, being autonomous, his acumen, skills have all been sapped while being away from his educational or professional circle for so long. And this lack is in performance increases peer pressure, creating even more problems for him.
Thirdly, research has proven that even after the discharge of these patients, there remains a process called the continuation of care, in which his family and other peers have to play a pivotal role, who completely lack psychiatric training at this time because they haven't interacted with him during this whole time and don't even know how to deal with him, mainly because he had been ostracized. And therefore, they're unable to cope with him, and so is the patient himself, which again makes his reinculcation difficult. So in order to promote acceptability, tolerance, not only in the patients, but also in the society, and to secure the well-being, recovery, self-worth, and autonomy of the patients, we proudly propose that they should be treated within the community and not outside it. Thank you.
You're welcome. Medical College will cross-examine the speaker.
Yes, hello. I would like to ask how you can justify that calling, sorry, 1 minute. How can you justify that saying admitting patients into mental facilities removes their freedom of will when most patients are admitted with consent? So there is certain criteria to admit a patient into a mental facility, and only when they consent to it are they admitted. So it's not really removing their freedom of will.
Okay, is that your question?
Yes.
Okay, well, very clearly mentioned in the contextualization of this debate as well, that when we are treating a patient within a treatment facility, within a psychiatric ward for a limited time, that actually falls under the ambit of treating him within the society and not outside it. Secondly, when you're going to isolate him in asylums, that is definitely going to be against his will, because he knows that he's going to be ostracized for his mental illness. And when he comes back, he's going to be looked down upon by his peers. That will instill so many counterproductive effects that can result after that, which I've already mentioned in my debate as well. He's going to lose his ability of being autonomous, his skills, his acumen, and definitely, no one wants to be ostracized for a mental illness. He wants to be socially connected to the people around him. He wants to be treated by those people who he's attached with, and he wants to remain a part of the society, because we cannot simply scapegoat these mentally ill patients as weaker sections of the society. And when you're ostracizing them in mental asylums outside the community, outside the society, that strictly means that you are ostracizing them. You are denying from accepting them as part of the community, because you're treating them outside the community and not within it. So what's your next question?
You mentioned that reintegration into the society will be difficult upon completion of the treatment. However, I believe that mentally ill patients anyway are not well integrated into their society. And that
thank you to the participants. Your time has elapsed. And now I would like to call Tiba Al-Bakri, who will negate the topic. Tiba, you have the floor.
Thank you. Mental illnesses are now recognized as treatable diseases, which begs the question, what is the best way to treat these conditions without compromising patient safety? Treating psychiatric patients in specialized facilities is the best way to fulfill both these criteria. To begin with, let's clear the misconception that mentally ill people are thrown into an asylum where they would be left to rot. This is an inaccurate and outdated image. A mental institution is simply a place for creating a controlled environment where triggers may be filtered out to ensure the optimal conditions for the patient's improvement. It allows for an intimate relationship between the patient and their healthcare team who provide the necessary therapies. Notably, psych wards facilitate group therapy, which allows patients to confide in people who share similar experiences. A study examining the outcomes of patients who received group therapy for depression found that 44% had significantly improved. Another significant pillar of treating psychiatric illnesses is medication compliance. A meta-analysis published this year found that almost half of the patients did not adhere to their psychotropic medications. A poor social support system was cited as an influencing factor of non-adherence. So logically, the supervision provided in psychiatric wards ensures higher rates of medicine compliance and creates a support system comprised of experienced and trained professionals. So I hope everyone can see that these facilities are specialized treatment centers rather than buildings where we merely store away sick individuals. The second major aspect we must address is patient safety. The WHO recognizes mentally ill individuals as a vulnerable group. This stems from issues such as physical and sexual abuse they are subjected to in the community. Moreover, self-harm and suicidal tendencies particularly threaten their safety. Research shows that mental illness is the most important risk factor for suicide. Thus, closer monitoring of psychiatric patients within a safe space offers to mitigate some of these harms. To conclude, mental institutions provide the best environment for treating people with neuropsychiatric disorders while simultaneously improving patient safety. Thank you.
Thank you, Tiba. Now I would request the first speaker, Faiza Khan, to cross-examine Tiba. Thank you. Faiza Khan, can you hear me? Okay, so I believe we will.
Okay, I can. Yes, I can.
Okay, go on.
Okay, first of all, I think that team opposition very clearly needs to understand the topic, the motion here today, that we are not against the idea of specialized treatment centers. We are arguing whether those specialized treatment centers should be present within the community or outside it. Your whole idea, your whole model is based on this very fact that you are promoting the idea of specialized treatment centers with no regard to whether treating them within the community or outside the community. Second, you talk about some intimate relationships. I want to ask you that even in a treatment facility or even in mental asylums, a doctor, a psychotherapist is not going to be available 24/7. They come here for on and off visits, like they come to a patient for once or twice a day, and the rest of the time they are surrounded by attendants. So don't you think it's better to replace those attendants by family members, by those members whom we have provided specialized psychiatric training, and that they will be able to treat the patients better because the patients are better attached to them?
I believe what you need when you are treating a disease is not your family, but an experienced professional. And being in these psychiatric wards will keep you in close proximity to healthcare professionals who have experienced such illnesses over and over again and know how to deal with each symptom as it comes up.
Okay, the next question is, how do you intend to re-inculcate the mentally ill patients into the society in your own very model?
When you are in a psychiatric ward, there is a lot going on to assess and rehabilitate you. So you will not be put into the society, back into the society before you are ready. And this is assessed by a lot of professionals, including healthcare workers and social workers.
Okay, you talked about physical and sexual, these patients who are suffering physical and sexual abuse. So I would like to tell you that the people who suffer from, who are inflicted with physical and sexual abuse, they have to be kept away from these abusers. Like when you're incarcerating them from the society just because they could not get love and attention from one probable relationship, and you're causing all that counterproductive effects by ostracizing them from the society. How do you justify that?
Okay, with this cross-examination session has ended. Now I would request the second affirmative speaker, Sarmad Arshid, who would present his views in the defense of the topic. Sarmad, please.
So now I'm going to highlight some problems that the patients face being treated outside the society, which are not present obviously when they are treated within the society. Living in their homes or such places, and then having a regular checkup by the doctor, or going to the treatment facility for just an hour or two for getting such specialist psychotherapy and anything else, and the rest of the time they keep connected with the community. First of all, we want to tell you that how closed spaces are not productive for a patient. That was mentioned in James A. Halston's research in 1987, that we in a mental treatment facility would provide a very limited environment. There is limited mobility. There is check on all the activities that a person performs. There is a 24 hours observation and the person feels just no more than a prisoner. The food is not of your choice. There is an enforced routine, and these things does matter because medication and treatment are already having an impact on his mood and behavior. And then when things are not going as he wills and as he can and as he would prefer, then this would obviously lead him to sadness and things like that, because living in the facility reminds him all the time about his illness. This does not let him forget that he is ill, and he is ill, and he can lead to a normal life, and this makes him worry about his health, and he feels overwhelmed. Second thing is the mental patient's company, that is very much harmful, as mentioned in the WHO mental health atlas in the country profile. We believe that not all the patients have same intensity of illness. Some have mild illnesses, some have severe illnesses, whereas in the treatment facility they are all placed together regardless of their illnesses. Then they start absorbing negative aspects of each other because their attitudes are at clash due to disease. They are having no bond with each other. They do not bear each other because of their different diseases. One has to bear his own illness as well as he has to bear the symptoms of others' illness. He has to bear a girl screaming with schizophrenia for 20 minutes, then a person with insomnia disturbing him throughout the night, and the person with bipolar disease crying for 20 minutes, and many such factors. Just like we believe that if there are two inputs A and B and both are giving input, then the output is obviously larger. But when a normal person and a mental person is there, then the negative effect of mental person subsides, being divided into two. So we thus believe that that person being his relative or friend can absorb this thing because he has blood relation or he wants his recovery, and that he has to bear for his sake. Third is the financial aspect. We believe that it is very costly to run a treatment facility. There is 24-hour shelter, food, electricity, sanitary equipment, and the staff pay. When a patient is admitted, he cannot work or earn something, and this is a burden on his family. If it is a private treatment center, then this is burden on his own pocket, and if it is public, then this is a burden on the government, especially in developing countries who cannot afford such things. And developed countries lead to more taxes, but when in society we only have to pay for the therapy, doctor, and medication, we simply replace house members with attendants that are much close to him and much attached to him and have much sympathy and with the minimum treatment they can do this. And this was mentioned in Journal of General Internal Medicine 2012 by Wolf and Retter. Thank you.
Thank you, Sarma. Those were really some well-versed points. Now I would request Fatma Itfana Muzammil, who can now proceed for the cross-examination. Fatma, please.
Hello, good morning. So I would like to ask the question. You spoke about 24 hours observation. What do you mean by saying that he's closed in an environment and has been enforced to follow certain things? Do you have an evidence that provides this infrastructure that you have outlined?
I just mentioned the James A. Halston's research in 1987, in which he says that he found several of the treatment facility patients who are very averse to not eating the food they wanted to eat, but they cannot arrange separate foods for anyone. Similarly, they were very averse to the different routines they all had at homes, but when there, they had to follow a very fixed routine that was something also very disturbing for some of them, and that hindered obviously their recovery when they are already being in tension of being observed all the day with the no touch policy, or we also want to criticize.
All right, I got your point. However, I would like to ask you, what kind of routines are you saying that are going to interfere, or what you are saying they are being averse? So what kind of routines are you trying to put light on? Because certain routines in medical facilities are done so that the mental health of that patient or of the individual improves. So what kind of medical routines are you talking about?
We already mentioned that it is very unpractical to decide a routine for each and every individual differently. So they make only one routine for all the patients without regard to their difference of behaviors, symptoms, routines, and illnesses. Obviously, they can't afford each one separately. The food they cook, the ones at the lunch, they cannot have different foods for everyone. So these are the practical aspects, and that's why we believe that when given a choice to a person to have been treated at home, then he would obviously never choose to go to the treatment facility, because this is the future of treatment of mental health patients. We believe that soon the
thank
treatment
you.
facilities are dwindling.
I'm convinced by your answer, although I don't know why you are saying that the foods can be different. I'm sure they have technology, or they have things got tapering, and they have protocols and criteria and what each patient according to the mental health requires. However, my next question to you is, what do you think about the mental and psychological burden on the family, who according to you would bear their state, emotional state, or their crying behaviors, but they themselves start having a number of anxiety disorders or depression because they have a burden and they are not able to take care of their own responsibilities? What do you think about that?
I already mentioned two persons, A and B, with A exerting a negative influence on B and B also exerting a negative influence on the A. Then in the clash, this negative influence builds up so large that it becomes unbearable for both of them, A and B, both the patients.
Samad,
But
please
if
wind up
only
your
input
answer.
is given by A, then obviously that input is less and will be half to both. And the B, when given some basic, you can say knowledge or basic training, he can easily learn to deal with
Thank you,
that person
Sarmad.
instead of
Thank you.
outcasting him out of his society.
Sarmad, your time has elapsed. Thank you.
Thank you.
Fatma will now speak in against of the topic. Fatma, please.
Thank you. So, according to Unattended Mental Health's Impact on Society, published in March 2016, communities prosper when the mental health needs of a community are met. However, unaddressed mental health illnesses or issues can have a negative influence on employment, family relations, local economy, local businesses, which could in turn lead to disruption in family and community relations. According to National Alliance on Mental Illness, in 2014, about 1 in 5 adults in America had a mental illness in the past year, and 4.1% had serious mental illnesses. So you tell me, with statistics as such, monitoring severe mental illnesses patients in a well-equipped institution with trained service providers is better, or risking someone under the care of family or under-trained community is a better option? More so, according to researchers, those who are trying to provide personalized care in a non-institutional setting soon themselves become tired, juggling between the increasing demands of the patient in terms of not only economic burden, but also physical and mental support. When they already might be having other responsibilities related to their own family members, they get physically exhausted, mentally drained. They themselves start developing depression, and this caregiver burden associated with depression can affect workplace performance. Definitely, they might even become careless in taking care of the patient itself, which may then progress to frustration and guilt, but prove as a severe threat to the patient. According to a Swedish study, 1/2 of family members claimed they have developed psychological or social problems, such as sleeping problems and depression of their own, to such an extent that they themselves now need help. I'm sure we as healthcare professionals cannot neglect the statements from the family's side. The Equality Act of 2010 makes it illegal to discriminate against people with mental health illnesses. But my dear colleagues, how many people of our society follow this act? Of all the related rising mental health awareness and how to treat it, let's certainly not forget that the stigma hasn't reduced an inch in the community, or rather society. People raise slogans, hold campaigns, but how many families with mentally ill individuals feel stigmatized to the level that they try to hide the illness and fear of people mocking them, cost issues, and whatnot? According to Mental Health Foundation, nearly 9 out of 10 people with mental health problems say that stigma and discrimination have a negative effect on their lives living in the community. Many people are of the opinion that showing up or exposing the difficulties faced by families while caring for them at community level are either overrated or think them as hypothetical. But those mentioned by mental health patients, but both those patients surveyed by the Priori group reported that their emotions and behavior put extra stress on their family, with one patient reporting that my addiction affected everyone close to me. Another mentioned that they isolated their family, and some even reported being physically violent towards members of their own family. Nearly all mentioned their loved ones became upset and worried about them. Would you then argue or disvalue their personal experiences, or what they have undergone, or what threat they have posed to the family members while trying to being taken care of in the community? In my opinion, we should understand and give importance to what's the priority. It's time we understand that patients with mental health illnesses need patient-centered care. It's their right, and our duty as healthcare professionals is to provide them with one. We cannot be selfish and hold them up in the community just...
Please conclude your speech. Your time has elapsed.
Okay, thank you.
Okay. All the participants are requested, when they're not speaking, please mute your microphone. Now I would request Sarmad Arshad, who will cross-examine the speaker. Sarmad, please.
Okay, now you talk that there will be some problems for the family. Obviously, I first of all said that there might be some very minor problems for the family that can be overcome by simple some acknowledgement, some information and some training. But when you are going to say that you are going to protect the patient from the stigmas, just because the society and the family and such people are very less acceptive to the mental illnesses, just because when a person is diagnosed he will be isolated, he will be cut off, then how can the family and the society learn to accept that person and relatability, developing relatability within the society by when you claim to isolate him in your model, whereas our model that promotes inclusivity? Answer this, please.
Okay, so first of all, when you spoke about how there are minor problems, no, they are not only minor problems. Sometimes it's really, it comes to violence. A person who's schizophrenic can listen to the auditory hallucinations that he hears, and he can literally harm his family members to the matter that it can kill. I'm sure this is not a minor problem. This is a major one. And second, when you're talking about stigma, this you're talking about inclusiveness, which can happen maybe after 20 or 30 years of trying to raise awareness and trying to make every family accept this model. It is not possible in the current community when there's so much stigma and people are fighting, people are mocking at the people. They're talking, they are disvaluing their genetics. They are talking about their violence. They're talking about family problems that have resulted because of this. Do you think in a society or community at this, we can leave our mentally ill patients who are so vulnerable at the hands of the community who has so much of stigma, who can hide their illness or who can harm them just to protect their dignity and to protect their respect?
So okay, now let me answer. First of all, you said that if a person with schizophrenia, he is at some stage, he's going to have some shock or he's going to kill somebody. Then we already said in the contextualization that in case of such very severe case, he could be shifted to hospital for a day or so unless his sudden attack subsides, just like a BP patient when he gets a heart attack or such medical emergency, brought into an ambulance and gone there. Then this is the same case as a sudden attack. And you need to realize that putting mentally ill patients in asylum and in treatment facilities will never lead to eradication of this stigma, because already you said that one of 5 people have mental illnesses. How on earth do you suggest that we can put such a huge portion of people in asylums and treatment facilities? And I am surprised at the conventional approach of the opposition 24 years ago in enacting the Americans with Disabilities Act 25 years ago. Congress
Okay,
found
let
that
me just tell you, answer you
institutionalization is
on this.
form
You
of...
to okay, give me a chance to answer your
Kindly
question.
My
keep your
question is
answers
coming.
short, okay?
I have 2 questions, sorry.
No, 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 please, no, please. Just this one, just this question, and kindly keep the answer short. Fatma,
Yeah,
over
sure.
to you.
What do you have
Yeah,
to
you
say
told about
this?
let me answer. You spoke about the fact that, like a BP patient, you can rush the patient to emergency. I'll tell you one thing. You imagine a mother who's staying with a person who has schizophrenia or his son. Okay, you just imagine this guy gets an attack. She's alone with him. How is she going to, first of all, control him? Second of all, protect herself from him, from his attacks. Third, try to get to an ambulance. Try to give a sedation or something that will calm him down. And fourth, reach the hospital alive or without any violent attacks from the sun. How do you expect that this whole protocol is going to work when the person gets this attack and he is not in control? I do not understand
Okay,
how.
Fatma, I believe that satisfies the
Okay,
answer.
there is a simple answer,
The
just a 1
time
minute,
has
2-second
elapsed. The
answer.
time has elapsed. Thank you. Thank you.
Okay, sorry.
The third affirmative speaker, Abdullah Ilyas, will now speak in favor of the topic. Kindly, all the participants mute your microphone. Only the participant speaking will unmute his microphone at the time of speaking. Thank you.
Okay, thank you. The idea is that my first and second affirmative speakers have already told you that why should we treat mentally ill patients within the society. I'll tell you how do we exactly do that and how do we execute with that. Bear with me as I walk you through a comprehensive, multifaceted strategy that involves different services and caters to all the needs of mentally ill patients. The first idea is that of pharmacotherapy, medication, a proven effective method that can easily be provided at home. Yes, as far as the issue of regular intake and dosage is concerned, it can be monitored by the family members if they're given due guidance or
awareness, something that we as proposition totally stand for. The second idea is that of psychotherapy, which is fundamentally based on a positive relationship between a doctor and a patient. That is very essential. How do we ensure that that relationship is healthy? We create a therapeutic environment at the homes of the people in their homely environment, because it changes the perception of the patient of the therapist from that of a nemesis in a mental asylum to a friend in a confident homely setting. That increases the chances of compliance and cooperation on behalf of the patient. Psychotherapy includes a lot of things such as behavior therapy, cognitive behavioral therapy, interpersonal therapy, relaxation therapies, etc., etc. All of which can, without any exclusion, be provided to the patients while keeping them within the society, and especially given the increasing use of telehealth and technology within the field of medicine. The third idea is that of family support. That is very essential. That is very positive and falls solely on our part. It is a well-versed fact that support from your family and your loved ones has a very positive impact on your mental health. Substantial evidences, according to WHO reports, demonstrate the benefits of involving families in the treatment of schizophrenia, mental retardation, alcohol dependence, and childhood behavior disorders are present. In fact, family therapy, when added to antipsychotic medications, proved to be more efficacious in preventing relapse, according to a journal published by Cochrane Collaboration. We have at this moment time family support associations such as the Alzheimer's Disease International, World Fellowship for Schizophrenia and Allied Disorders, that actually extend the services and help to family members in trying to help them to cope with the members of the family who are mentally ill. And they've borne absolutely fabulous positive results, and they are continuing to do so. Then there's the idea of support and peer groups that function within the community. People with similar problems share their experiences, meet once or twice within a week, and they are headed by or supervised by a certified therapist. This fulfills the need of the relatability factor, and that is sufficient if that is fulfilled once or twice a week. The next idea is that of psychosocial rehabilitation, a process that offers the opportunity for individuals who are impaired, disabled, or handicapped by mental disorder to reach their optimal level of independent functioning. It involves both improving individual competencies and introducing environmental changes. This includes vocational rehabilitation, employment, and social support networks. These are actually being implemented and done through labor cooperatives in countries like Argentina, Brazil, China, Spain, Germany, Cote d'Ivoire, Italy, and Netherlands, etc., etc. Then there's the idea of assisted outpatient treatment, which is there for severe mental illnesses, and also within the community, and that is being implemented in more than 46 states in the United States of America, including North Carolina, Florida, and USA, and have borne fabulous results. The idea is that this is a multifaceted strategy that leads to that caters to each and every need of a particular mental ill patient. And given
Please
the fact
wind
that
up
this
your
can be
speech in a sentence or two, as your time has elapsed.
a couple of
Yes,
sentences,
please. Yes,
that
please.
this strategy can be implemented while keeping the person within the community and at their homes amongst their loved ones, without treating them as an outcast. Because of this moral obligation, because of all the pros that we have in our model, we strongly believe that mentally ill patients should be treated within the society. Thank you.
Okay, thank you. Now, Amara Shakil will cross-examine Abdullah. Amara Shakil, over to you.
All right, so I would like to first address the idea of pharmacotherapy proposed by the opposition team. You can train the family members to administer the right dosage of the drug, but what is the guarantee that they will? In an institution where there are physicians and nurses and professionals who are trained for this very purpose, isn't there a better chance of psychotherapy being monitored regularly? And
I got your point. Yeah. So the problem is that in cases of mental illnesses, the patient is supposed to be medicated for a long period of time. If for a person with epilepsy, he needs to take medication for a couple of years, or for 3 years for that matter. You cannot possibly keep a particular person who is epileptic and who is probably going to have an epileptic episode once in 6 months, or once in a year for that matter. You cannot keep him in an asylum for the sake of monitoring his medicine. You have to, at the end of the day, guide and make sure that his family members and his guardians are aware enough and can monitor that on their part, because mental illnesses, inevitably all of them, whether mild or severe, do take a long period of time to be treated, and during their entire treatment course of treatment, they need to be medicated. You cannot possibly keep a person who is mentally ill and has very much chances of being recovered in a mental asylum, because that puts them out of social interaction, isolates them from the community, and puts them behind in the life for like a couple of years. I hope that answers the question.
All right. My next question is, you mentioned that, okay, psychotherapy can be implemented at home, but like another one of your speakers mentioned about negative influences in 2 ways. So if the treatment of a mentally ill patient at home can negatively influence the family members, this increases chances of abuse of the antipsychotic drugs that are to be given to the patient by the family members. Also, I want to address the idea of you mentioned that treating the patients without treating them as an outcast. The stigma surrounding mental health is so great that to at this point in this era, to say that you can deal with stigma just by not treating them outcast, just by not treating them as an outcast, how is that exactly possible?
Okay, fair enough. The first idea of psychotherapy, what our proposition stands is that when you're talking about psychotherapy, for any person who is taking psychotherapy, a
Do keep
psychotherapeutic
your
session.
answer brief. Your time is
I
about
I'll
to
keep
is
that.
almost as
Okay,
elapsed.
give me half a minute. Give me half a minute.
Okay,
I'll
sure.
a person needs psychotherapeutic sessions once a day, twice a day, or once a week for that matter. The rest of the 22 hours or the rest of the entire 72 hours within a week, he needs not to be exposed to a psychotherapeutic professional. For that matter, we say that the rest of the time he can spend with his family members. And when you're talking about the other family members, they should be coordinated and guided by the family healthcare professionals, because that will produce more conducive results that is
Okay,
proven with
Abdullah,
research.
thank you. Thank
Sir,
you.
sir, give
Thank
me
you.
just 10 seconds. 10 seconds. One question is unanswered.
I've already given you
Regarding the
30 seconds. Thank you, Abdullah.
okay, I'll answer that
Now
in the
it's the
rapid fire.
turn. Thank you. Now it's the turn of Amara Shakil, third year Dubai Medical College. Amara, please.
All right. So, deinstitutionalization began in the late 1940s when many groups were being incorporated into mainstream society. The belief that mental hospitals were cruel and inhumane, the hope that new antipsychotic medications offered a cure, and the desire to save money drove the movement of people with severe mental illnesses from hospitals into the community. However, it did not work out as well as expected on any of these three fronts, especially with these individuals being found in the worst of environments. So, with this, the questions that I want to address are the mentally ill at increased risk of violence within the community? And are the mentally ill themselves violent? With the influx of severely mentally ill patients into the community began the exacerbation of a bigger problem associated with them, which is that of crime victimization. Symptoms associated with severe mental illness can compromise one's ability to perceive risks and protect oneself. The decrease in the number of patients in hospitals and residential services has been associated with a corresponding increase in the ratio of such individuals among the homeless. From observing several studies and interviews of these patients about being victims of violent crimes in several American states, UK, and New Zealand, it can be concluded that the degree of violence subjected to is significantly higher in mentally ill individuals when they're left to thrive in the community, especially if they're homeless. I shall now move on to assess whether mentally ill individuals are more likely to commit acts of civil wrongs or violence. The most important and independent risk factor associated with increased risk of violence in psychiatric illnesses is a long-term substance use disorder, which shows a fourfold increase in the risk. In an era where substance abuse is rampant and this culture is contagious, it is not right to ignore that access to drugs in a lot of communities today is very easy, and resorting to civil wrongs to obtain drugs is not uncommon either. The desire to save money and cuts in funding are the primary reasons for lack of services and difficulty in accessing treatment, and this puts people who need it in situations where they involved in criminal activity. The result of such events is the flawed perception of a causal relationship between psychiatric illness and criminality. This has led to people with mental illnesses being arrested for petty crimes and sent to prison in disproportionate numbers. Within an institution that caters to their needs, they are not in an environment where they're likely to commit crimes. Therefore, firstly, the likelihood of criminality is lower, and secondly, they are not punished unjustly for acts they commit as a result of their mental status. In conclusion, the safety of mentally ill individuals and the communities they reside in both are of great importance, and hence, my team believes that the right approach to solving these issues is by way of psychiatric institutions and treatment facilities. Thank you.
Thank you, Amara. Now, Abdullah, you may proceed for the cross-examination.
Okay, I basically have three questions, and I'll ask those questions that you can answer them later. Answer them at a go. So the first question is that how do you intend that you can counter the stigmatization if you keep on throwing all the people who are mentally ill into asylums and into treatment facilities that are completely detached from the entire community? That will never, even in the longer run, counter the stigma. Answer that question. The second idea is that the problem
Can
I
I
have with
please
the
answer your question first?
okay, answer.
Okay, so now that we're talking about stigma again, don't you think it is a better idea to deal with the stigma to whatever extent is possible before we let these patients go back into the community again?
Okay. Uh, the answer to that is traditionally we have been doing so. We've been doing so for centuries. It doesn't work. Mental asylums have been always doing that, and that
Exactly, it
doesn't
doesn't work.
eventually help.
It doesn't work.
Can you please, that eventually mental asylums do not help in countering the stigma. Moving on, the idea of violence, they being victims of violence. If a person is a victim of violence, a mentally ill patient, you do not punish that victim by putting him into a treatment asylum. You target the culprit who was violent with them, and you punish that. That is the exact problem I have with the opposition. The third idea of them being violent and being violent, having violent tendencies, and being a threat to the people, you need to understand that there is a broad spectrum of people who are mentally ill. A very few people have the tendencies of being violent. In those tendencies, you have options like assisted outpatient treatment, and you also have the option of trying to confine them within their homes and limiting their social interaction as a last resort, which is still way better than putting them in a treatment facility.
All right, so you mentioned that the spectrum of people, of mentally ill people who indulge in violence is small. In the beginning of my speech, I mentioned that I'm talking about severely mentally ill people, and majority of the of severe mental disorders actually uh, show these symptoms because of their disorganized thought processes and their inability to perceive problems as they are. They do react with violence.
Exactly. The idea is that you're putting them through therapeutic actions that will obviously treat them in the longer run. And during the course of the treatment, you have a lot of other factors that I have pointed out. You have support groups, you have peer groups, you have family support programs, you have family associations, you have pharmacotherapy that actually work to reduce the intensity of the symptoms and also help to cope them with the
Thank
triggers
you,
that
Abdullah and
actually
Amara. With
help them
this, your time has elapsed.
make them violent.
Thank you. Thank you.
Thank you.
Ladies and gentlemen, now two members from both the team will participate in the rapid fire round. The participants representing King Edward Medical College are Abdullah Ilyas and Sarmad Arshad, and speakers representing Dubai Medical College are Lubna Lutfi and Tiba Al-Bakri. Participants, you can start.
Sir, with due
I'm
respect,
sorry, one second, one second. I need to make a change. Instead of Lubna and what's her name? Instead of Lubna and Tiba, it's Hira and me, Fatima Irfana, who will be taking part in that.
Hira
and
Fatima Irfana.
And there's a change in part of King Edward as well. It will be
Yes,
Abdullah
please.
Ilyas and Abdullah Saeed who will be participating in the rapid fire instead of Sarmad.
Kindly do let the organizing team, Sir Walid also. Kindly do let him know too, okay?
Okay,
Your
sir,
team
let him know.
leaders can text them. Thank you. Okay, you guys can start.
Okay, so from
yeah.
Okay, so we'd like to ask you the question about the fact that when you say that you want to get them treated in the family environment, don't you think about the sandwich generation that happens between the people who are taking care of the elderly people who might be having mental illnesses while they have responsibility to take care of their own children and many other responsibilities? Don't you think on their part the care will be neglected when it comes to taking care of the mentally ill patients?
There is distortion in your voice. Could you please repeat? I skipped some of your words. Could you please repeat the question?
Okay, sure. I said that don't you think there's a sandwich generation? The generation you mean the person, an individual. Suppose the elderly people in the family are the ones who are mentally affected. That means the parents, and this particular individual who's taking care of the mentally ill patients also has other responsibilities and also has. So basically, they're a sandwich generation. They have a lot of other responsibilities. Don't you think in trying to fulfill all the other responsibilities, they are going to come down in their care or be a little careless or not be able to give the appropriate time for cognitive therapy, other social skills for the mentally ill patients?
Fair enough. So one of your speakers pointed out that in the US, 1 in 5 people are patients of mental illnesses, and a majority of them are elderly people. Don't you think it's inhumane or morally and ethically highly questionable on your part that you suggest that every 1 in 5 person who is facing a mental illness condition is supposed to be put in a treatment facility? The way forward and in the longer run, which will help the society in a more favorable environment, is not to put them in treatment facilities, but to allow and guide and train their family members to cope with their routines to cope with them. They can hire the provision of mental health cares. You have support organization, you have peer groups working within the community that can alter and they can match their schedule in order to treat a particular patient. But throwing them in treatment facilities, A, is counterproductive because of the negative environment of the people, and B, is largely impractical given the fact that there are so many people who are patients of mental illnesses. Thank you.
Okay, I would like to make a point over here that the team is constantly using words such as throwing as, incarceration, and prisoners. First of all, we'd like to point out again that these are patients with mental health problems and they're similar to any other patient. So first of all, we're not throwing them, we're not locking them. They are being admitted as patients, number one. Number two, like any patients, they will be allowed to see their family, they will be allowed to meet their loved ones, and they will be receiving the therapies they need in the mental health facilities.
The problem is that you suggest this on an ideological basis, but when you're talking about practical grounds, when you talk about history, mental asylums have this highly bad repute in terms of treating patients in a very negative manner, and their social interactions, without a doubt, are almost non-existent, and they are treated against their own will, in a sense that they are not treated according to their own will. There is a lack of compliance on their part. So that is why we suggest words such as throwing out, because you treat them as an outcast and you abandon them into
Okay,
a treatment
thank you. I
facility.
would like to answer that question. I would like you to support your your argument with some statistics.
Fair enough. 25 years ago, in enacting the American with Disabilities Act, US Congress, one of the biggest platforms out there, found that institutionalizing is a form of disability discrimination, and that institutionalizing is one of the greatest deprivation of civil liberties imposed on anyone. We have WHO report on mental health back in 2001 that just suggested that putting people in treatment facilities and confining them in closed grounds has a very negative impact on their mental health, and when they're reinculcated into the society after being isolated for a long time, the actual performance environment isn't one that is familiar to them, and because of that, their reinculcation into the society becomes highly difficult. So there you have two references that suggest that endorse my.
Okay, I'd like to ask a question. I'd like to ask
Yes,
a
sure.
question. You told that putting the patients in institutions is more like sort of inhumane or a bad state there's a bad state in institutions. But like, I would like to ask you, how do you then think that the family with which they'll be left for the community care will not be abusing them, will not be abusing them, or they not abusing the family? How do you then how do you advocate for the protection of the mentally ill as well as the family itself?
And another point over here I'd like to add is
Let
that
me
she
answer. Let me answer first.
Okay, I'll give you the floor. Yes.
So I'll ask you for that matter. If by God forbid, if you get a sort of a mental illness, whether your family will be able to take good care of you, or whether if you're put into a treatment facility along with patients who have the same or even worse some symptoms of mental illnesses, and you are attended constantly by people who are strangers to you, what do you think? Which will bear positive results for you? The idea is that family, with small number of exceptions, do inevitably care for the people, and in coordination with the mental health professionals, that breeds a very good results. I've already told you how we had Cochrane. There are several substantive reports which
Yeah,
suggest that
fine.
family
I
support.
got your study, what study you pointed out, but it's you cannot make it generalized. First of all, the situation you showed was hypothetical, but it's as well saying that okay, my mother will be able to, probably if you get a deep cut, you'll probably be like, no, I'll get the stitches only done from my mother and not from the person who's trained in the emergency department. It's almost close to saying that no, I'll not go to anyone who's more trained. I'm just going to rely on my family for everything.
No, the
Now that
idea
you're
is that if
talking about family, I would just like to point out, with any illness there is physical or mental, I would like my family to receive the best healthcare there is. Number one. Number two is you're pointing out that all the mental health patients, they receive one standardized care in the facility, while that is very, very wrong. The care is tailor-made to each patient. So not all of them receive the same therapy. Not all
let
of
me
them are
answer
clustered
answer all
together
of,
in
let me
one room, and
answer
not
all
all
of
of
those
them are
3 points.
influenced by each other.
Let me answer all of the 3 points. Firstly, we are by no means saying that we are inhibiting, or we are limiting the provision of better healthcare professionals. The strategy that I've presented, the multifaceted strategy that I presented, is one of the most conducive plans that you can come up with in order to treat mental illnesses. The idea is, in order to, whoever asked the first question, whether you'll be you'll be treated with the family or not, there is this idea of probability. So if you have 100 patients who are mentally ill, about 95 or more than 98 people would want to be treated within the community. On a secondary level, even if you want mental health care to be there, to be present, you can take that, because you're not even getting that in throughout the 24 hours in a treatment facility. And the last question, you need to understand that in a treatment facility, what happens is there is more generalization. So if you have a unit of 100 mentally ill patients that are going to follow a particular routine, that are going to be treated by the same that are going to be receiving treatment and supervised by the same attendants and same doctors, the tendency for them to be generalized is more than any one particular individual who is being treated within his or her own comfort zone being treated. So that I suggest. Now I answered enough of your questions. I need you to answer 3 questions on the part of the opposition.
Yes,
in your
please.
model, how do you believe that in the longer run you will ever be able to reduce the stigmatization? In our model, we suggest the involvement of psychosocial rehabilitations, employment opportunities, peer groups, family support groups that eventually create a more inclusive environment for the people who are mentally ill. In your model, there is absolutely no indication that in the longer run stigma will be decreased. That is
Okay,
the
let
idea
us
of being
answer it. Okay, let us answer
Can
it.
we
We got
answer
your
one question
question.
at a time, please? Yes, Irfana.
Yes,
Yeah,
no problem.
we got what you're saying. I don't understand why the opposition continuously talks about the stigma, the idealistic situation where all the community workers or the self-help groups are going to work for a mentally ill patient. What about the corruption that is going on? What about, and I would also like to state the fact that mentally ill patients also get self-isolated because they also feel that they are harming their family members or the community people because of their behavior, because of their emotions, because of the way they are behaving. So when you talk about the fact about stigma, you also know, I told you in my speech, people raise slogans and they hold campaigns, but to be very honest, the stigma hasn't reduced. It's only in talking, it's only in speeches, but there's no evidence that the stigma has gone down a substantial amount of rate and people are accepting or behaving a certain way with the mentally ill patients.
Again, 30 years ago, the idea of this debate happening was very less likely, but the fact that we are actually addressing this thing is a testimony to the fact that even at a very slow rate, we are progressing in a society where there is increased awareness of mental illness. And that is largely due to the fact that we have had people being treated as normal people, as integral part of the society, even if they are mentally ill. Because not all mentally ill patients are absolutely of no use to the society. Understand that. On a secondary level, understand that when you're talking about mental asylum, the model that you guys are presenting is a rather conventional one. What I am presenting is a rather an up-to-date model. So any problem that you actually state that there is present in the status quo is an eventual product of whatever has been happening in mental asylums. And that by using the mental asylums, we have not been able to cater to those problems. For that
No, we
I
are
would
not
like to
saying
answer
that.
this question.
Yeah,
Mr.
sure.
Abdullah, I would
That's
like to
very
answer
reasonable
this
to do.
question. You mentioned that we are putting forth a very conventional model. First of all, I'd like you to recount when did we mention that, because in our during our argument we
Can
were
you keep
mentioning
your answer
things like,
short as the time has elapsed?
okay. In our argument, we were talking about therapies, behavioral therapy, psychosocial therapy, and we were talking about integrating them into the society properly, while your team was continuously using words as incarceration, prison, throwing up, locking up. So I just want to ask you the question: who is more conventional here, us or you? Thank you.
We are basically when we use
So
such
with
intense terms.
this session comes to an end. Thank you both the teams, and kindly do update Sir Waleed or your team members in regards to the participants of the rapid fire round, so as to avoid any confusion and that you can be awarded points accordingly. Thank you. Now I will call Abdullah to give his team's concluding remarks. Abdullah Saeed, I believe. Abdullah, please.
Am I audible?
Yes, you are.
So I'll begin with the ops case. They begin with saying that mental illnesses shouldn't be related to socio-economic factors and daily life problems. They are basically saying that in a mental asylum, they will be given all the sorts of facilities and safe environment with constant supervision, and will be given every patient will be given his due importance and will be treated according to his symptoms. whereas this is totally contradictory to the reality. All the patients are kept in one space, and they have to bear each other on daily basis. And the second speaker of the team opposition, they said that close monitoring is required because the patients can be subjected to abuse within the society. So in asylums, they are safer. And they also said that specialized treatment centers are better for their treatment. We totally explained in our contextualization that we are not against the monitoring and treatment of mentally ill patients. We are just saying that when we want to treat them only when it is needed, because mentally ill patients are not symptomatic all the time. When they experience episodes or when they need crucial treatment, they can be shifted to the hospitals and wards. They can be kept under supervision, but only for a limited duration of time. And when their symptoms symptoms subside and they are out of the danger zone, they can be sent to their homes, and they should be allowed to spend time with their families, spend with time with their families, which will be very much therapeutic for them. So our third affirmative speaker also came up with an alternative model and clearly explained how proper treatment facilities and care can be provided to the patients within the society. He said homely and friendly environment can be created within the homes with the therapist, because the patient will be more comfortable talking with the therapist inside his home, and will cooperate more with the therapist. And he also said that for just monitoring the dose of a mentally ill patient, you cannot keep him in an asylum under constant supervision. This is also basic violation of human rights.
Thank you, Abdullah. Thank you. Now, Hira will conclude this session. Hira, over to you.
Respected committee, I hope my teammates have had a positive impact on your thought process. People with mental health conditions deserve just as much support and compassion as people with physical health conditions. They have no symptoms, but they have a longing for something, for care, which they themselves can't explain, which the community members or family members not aware of the disease progress or process may misinterpret. Yes, so it is further our responsibility to stand by them, support them by providing the best approaches to treatment type, duration, and facilities. The two sides of the argument are whether mentally ill patients should be treated within the community or outside it. As a healthcare provider, I say one size does not fit all, while the other team continuously use words like, again, I'll mention incarcerated, prisoner, while these are patients and not criminals, using such deprecating language already adds to the aforementioned stigma. And contrary to what the other teams believes, treatment plans are patient-centered, and each patient has an individual patient plan centered to them or tailored to them. In conclusion, fellow debaters, respected doctors, we are beyond winning or losing this debate, but rather we are here to provide and discuss solutions. Of course, integrating mentally ill patients within the community is an important element in the care plan. However, institutionalized care is an inevitable necessity in so many cases for the betterment of the patient and their surrounding. And this can be done by mental institutions that provide excellent treatment for mentally ill by close surveillance and by medical compliance, ensuring patient safety is best within the facilities. And this is also done by preventing aggression towards the mentally ill and the aggression of the mentally ill towards the community. Thank you so much for your time.
With this, the session has ended. Now I would request the Honorable Chair to give his views in regards to the proceedings of the event. Sir, please. Sir, kindly unmute your mic. Your mic is muted. Yeah. Thank you, sir.
Thank you, Herar. My name is Dr. Shahid Sharif, and I'm Vice Chair APPS UK. Great debate, and I enjoyed the first session and enjoyed the second session more. Both teams has presented very well prepared, and good arguments in favor and against. I'm going to reserve my judgment instead of announcing it here. I'm going to submit my form and let the other judges also make a decision about this round. But it's a great start of a debating society and international level. And to me, it looked like I was sitting in an auditorium or in a hall. So enthusiastic and lively. So great experience, and I thank all the attendants, all the people who worked for it, and congratulate everyone. Thank you.
Thank you,
Batul,
sir.
please give your remarks.
Hello, everyone. Again, like the professor, I would like to acknowledge the teams. They have done a great job. I admire their preparation and the evidences that they brought forward. Now, I will, however, present some general comments. I know that a detailed assessment will be provided by all the judges. And now, mental health care and community mental health care and care in an institution is very debatable, and you have picked a very good topic. However, in some of the evidences brought forward were probably foreign evidences to the region, to the Emerald region, or to the Middle East region. We would hope for debaters to consider in the future to look at the studies and researches that have been done within the area. And my understanding is Pakistan and India and probably other countries in the region are very rich in conducting a serious set of research in your area. So that's number one. In relation to the second comment that I would present is that debates are not to prove a point. Debates are to present, discuss, but then probably at the end come into some sort of concession. And here we are looking at such an important issue that definitely both the institutionalized care and the mental health community care are essential, given the state of the clients. At the beginning, they are in the institution, but later they are in the community. And that's a conclusion that we should all reach together as the medical students presented. And we would hope that debates does reach into such an end. In relation to the rapid fire rounds and in relation to the conclusion that both groups present, it becomes kind of a repetitive of what they already presented. I would advise that if you go into debate in the future, your rounding up and your concluding remarks should address a common ground for both groups so that we all learn from this debate and come out with proper strategies for mental health care. And really, I enjoyed the session thoroughly. The groups were very composed, they were very mature, and I really thank you for inviting me. Thank you very much.
Thank you, Dr. Batul. Dr. Harar will be announcing the result for session 1 and session 2. Dr. Harar, please go ahead.
Thank you, sir. So now we have the results of the first two sessions. The winner of both the sessions will participate in the third and the final round. The winner from the first session is Team B, Dubai Medical University. Congratulations. And from this session is Team A, King Edward Medical University. Congratulations and well done, everyone. The third session will be held after a 10 minutes break, and the topic for the final session will be inculcated to the participants and the judges soon. I would like to conclude by saying, what is the point of intelligence if it's to be kept in a cage? Let it roam freely against all the odds, questioning every rule, every norm, every culture, and every question. I thank you all.
Dr. Azhar, can you please announce the team members of the winning teams? So to avoid confusion,
Okay, in session 1, Team B, Dubai Medical University, the members are Fatma Maryam Muzammil, Rehab Farooq, Leena Khyati, Tarab Iqbal, and from the second session, The winning team, Caregiver Medical University. Participants are Abdullah Saeed, Faiza Khan, Sarmad Arshid, Abdullah Ilyas, and that's it. Thank you all. Allah Hafez.
Thank you, Dr.
When will the final match start?
Are you ready? Are you people ready for both teams?
No, we just got the result. We need some time to prepare for it.
Okay. You can take, I think, 5 to 10 minutes maximum.
At least give us 10.
Or
10,
our
15.
next moderator also announcing the third final round topic. Let me check with Dr. Danish. Danish Ali Khan, do you have the topic for third session? Danish Ali Khan.
Waleed, can you hear me?
Yes.
Okay, so Waleed, the topic for the third round is the COVID-19 pandemic lockdown, health versus economy. So this is the topic for the final round of the debate.
Thank you.
And who is the proposition and who is the opposition?
So I think Waleed will make that clear. So Waleed, can you please make that clear? Who is the opposition and who is on the government side?
Please wait for 5 minutes. I will be back.
Okay. Waleed, please clarify that just shortly in a minute or two so that the guys can prepare accordingly.
Can I just say something? If it's okay with all the judges, would it be okay to give us maybe like 10 or 15 minutes to prepare, considering the other team just got done?
I think we will
agree
that's
with
that.
Is that okay with everyone?
I think we will agree with that.
Okay, thank you so much.
And please let us know whether King Edward is proposition or opposition.
Abdullah, as you know, just the finalists have been just announced. So, Waleed, if you can hear me, I would like you to please ask Dr. Danish or just ask any organizer who is just going to make or announce the teams for opposition and the government. Waleed, do I have you on board?
Please give me a minute.
Okay.
Assalamu alaikum to the panelists of the third session.
Walaikum salam.
Can anyone please write the name in the chat box for the session, for the final session name? This is Dr. Majid from Australia. Thank you.
Sir, the topic for the final round is COVID-19 pandemic lockdown, health versus economy. So this is the topic. I can also write it down for you in the text box.
Yeah, please write it in the chat box. Thank you. Thank you.
Sir. You're welcome, sir. So if the honorable judges can hear me, so we have given a preparation time of 10 to 15 minutes to both the teams. So we will be back with the debate when the prep time is over. So please bear us for that.
Sounds reasonable. So have you guys been joined it from the early on and been here for the last several hours?
Sorry, sir, I could not get you.
So I'm just wondering if I'm the only panelist who showed up 10, 15 minutes before, or are there others like me?
We were here
just from Australia. We're just joining now for the third session.
Wonderful.
I have been with you since very early stage, nearly 5 to 10. So our time. I'm second from top left, Hafez Ahmed. So I have been.
Ahmed.
Alaikum salam.
Danish, please check your website.
Remember, I have given the Quran reading as well at the very beginning. So yeah, I have been continuously enjoyment, I would say. Is very, very good. I would only think that we perhaps needed 5 or 10 minutes break between the two first debates for a coffee fill or something like that. But otherwise, I think it went on very well.
Yeah. And I was also suggesting that, like, for example, after each group, they give the judges like half a minute to fill because till the last statement of the debaters, we need to listen to them before we go into the forms and fill the forms. So probably a minute or so to be given following the debate to fill that form, because the form is user-friendly and it's very fast, can be done within a minute. But like for me, I was engaged in listening rather than filling the form. And then to my surprise, I realized that the results were out immediately after the debate. So that's a point to remember for the future. Thank you.
I kind of totally complete with Dr. Mohandas that might be the best way forward, that we do in the next session, make sure that there's some time for people to actually assess and then respond rather than immediately do so.
And also,
This is Mohammed
I assume there were some sort of voting. So maybe people would disagree. Some would go one direction and others would go the other. You need time for that to be decided, not just mentioned. I don't know if you communicate between yourselves without us observing that this is something different. But if you need to see the opinion of each one and count votes, you needed time for that.
Yeah, exactly. Thank you. Exactly.
Sorry to interrupt. We're still waiting for to be told whether we're going to be proposition or opposition.
Danish?
Right. All right. Yes. Can you please all hear me for a minute? So the government site is from Dubai Medical College. That is Team B from Dubai Medical College will go in favor of health, and Team A from King Edward's Medical University will go in favor of economy. So am I clear on that?
Yes, you are.
So that means our 15 minutes preparation time starts from now.
If you guys can make it in 10 minutes, that would be much better.
We will
Pretty
try
difficult
our
to
best.
manage it, and we'll try our best.
Yeah.
All right. So Team B from Dubai Medical College will go in favor of health, and Team A from King Edward's will go in favor of economy.
By health, you mean that they'll be favoring lockdown in a coronavirus pandemic, and we'll be going for not opting for lockdown in view of economic preferences, right?
Yeah, exactly.
Okay, thank you so much. We'll join back in 15
You're
minutes.
welcome. You're welcome.
Till then, I think we can have our judges to have some remarks. If anyone wants to speak, please go ahead. Dr. Yusuf.
Thank you very much, Yusuf Ahmed. I'm the chair of Australian Association of Pakistani Professionals. By day job, I'm a family physician in Australia. I think it's great to be here and listen to all the young leaders from Pakistan and Dubai. I think it's a very interesting topic. So we look forward to settle this discussion today at last, I think, happening all over the world. But I'm sure everybody here will settle this argument one way or the other, whether health or economy is more important in this lockdown. So look forward to hear your debate.
Thank you very much. This is Dr. Majid Naeem from Australia. I'm the president of Australian Association of Pakistani Professionals. As Dr. Yusuf said, looking forward for this very interesting topic. And I'm sure, this topic will have a lot of interest for the judges as well. So looking forward for the session. Thank you very much.
This is Dr. Mohammed Rashid Hussain from Brisbane, Australia. I'm one of the judges for the final session. Looking forward to an interesting debate. If all the participants are listening, because I've been logged on for a while listening to your round two, please speak slowly and make sure that we can hear every sentence and every word you say. Thank you very much and good luck.
We haven't started yet, so I perhaps fair to make a general comment. If I were a debater, if I were one of the two teams, I would find it very difficult to start or even to have an opinion, because the two are extremely important. You can't compromise health, so we need to maintain that. You can't compromise economy, so we need to maintain that. So they will either reach a common consensus that both teams will be saying exactly the same thing. Well, I don't expect a strong polarity to be observed in this thing. Otherwise, it will be easy for people like, I don't know, Donald Trump to come with a final say about it. But that never happens because the two are extremely important. And I will be very surprised that one of them will take 1 point without addressing the other. So whoever chosen that is really putting a very heavy task in the hands of these young people with only very short time to prepare.
That's true. I totally agree, at least from the point that this will be interesting. But
it will be interesting to us, but not to them.
These are interesting times.
I'll just request another judge from Australia, Dr. Khyber, to please introduce himself. I'm sorry, I think I know he's joined up, but maybe he's still unmuting himself. Dr. Khyber will be another judge from New South Wales in Australia, and his specialty is epidemiology, and he is heading the COVID response in New South Wales. So highly experienced in this field. So I think he'll be quite, I suppose, a resource for this session, especially the topic being COVID lockdown. I think that today's chair is Professor Muhammad Waqar Azim. He's here as well.
Assalamu alaikum, everyone. Thank you so much for all joining. Just briefly about me. I'm currently in Doha, Qatar. I'm the co-chair of APPNA Merit Program, and I'm chair of psychiatry at Sidra Medicine, Qatar, and professor of psychiatry at Weill Cornell Medical College, US. And it is so heartening to see all the enthusiasm. I see actually judges being more enthusiastic than even medical students, so that's even better. Very valuable comments, and it's such an important topic. Looking forward to the conversation. And it's great to see all our friends in Australia, UK, and Middle East, and Pakistan. I can't imagine a better forum than this. So thank you so much, everyone.
Yeah, thank you very much, Professor Waqar. It's nice to see you after the RMC days. So it's a pleasure to meet you.
Yeah.
And we are looking forward to welcome you in Melbourne, because you promised to me that you will visit us. So looking forward to see you over here.
Inshallah.
Great to see you, Waqar, after our medical college
Assalamualaikum.
days. Walaikum assalam. Lovely to see you.
Great to see you too.
I believe Dr. Mariam has risen her hand.
Yes,
Yeah.
excellent topic. Very much true to the time that we are going through at this time. In US, a lot of debates are going about COVID-19 and how the pandemic is affecting the economy versus when to let go of social distancing and how to deal with PPE and contamination issues. In addition to family issues, we could not have a better time to discuss it than today.
You're very right. Let me apologize first. I've been saying all these things and I haven't introduced myself. My name is Mohsin and I'm a consultant in critical care in the UK.
Thank you. And I think Dr. Khyber has joined us, so Dr. Khyber can introduce. Even Dr. Yusuf has given the introduction.
Thank you so much. I'm Khyber Ashraf and I work for New South Wales Health. I'm a public health professional and I'm currently managing the COVID-19 response in New South Wales. Thanks. Thank you.
How many medical schools are participating in this debate? I see that there are two teams, but are there other participants from other medical schools?
Ma'am, for right now, we only have two teams participating. That is the Dubai Medical College for Girls and King Albert Medical University from Pakistan. So in the first phase, we just have two colleges participating, and in the very near future, we can also have multi-institutional debates, inshallah.
We will also recommend a multi-professional debate between health professions, including, as you mentioned, multi-institutional. That would really enrich the debate, particularly, for example, between physicians and nurses or physicians and midwives. It will be excellent.
तुम हलवाई हो?
in the future with these kinds of downtime, when we may have in between the debates, perhaps having a little bit of a background about what Merit is doing, APPNA Merit, that might be helpful.
Absolutely.
So if all the participants can hear me, we are just left with a prep time of 3 to 4 minutes. So we will be formally starting the debate in 3 minutes. So I would like to have all the participants and all the judges on board when the debates get started. Thank you.
Will the final winner be dependent on this last debate?
No, madam, the final round will be judged independently and will have a separate score. So that is totally independent of the first two sessions.
Excuse me.
Yes, ma'am,
Hello.
please.
Yeah, I was wondering in relation to the scoring of the third debaters and in its making a decision based on the third one of which institution win this round, given the fact that the third group did not get the ample time to prepare for such an important debate and very controversial debate, as the gentleman at the beginning mentioned from, I think, Australia, or I'm not really sure, or UK. So maybe this will be following our assessment as judges, that your team would sit together and look at this issue of how do you decide which institution wins, given the fact that one did not get all the criteria that the first two received in terms of the title of the debate and the time for the debate. But we leave this to you to decide. Thank you.
Thank you so much, ma'am. But ma'am, the topic for the third round has been given in the early morning. So they had the topic beforehand. We just had to, after the two sessions, I just announced the opposition and the government side, the team that will be going in favor of health and the team that will be going in favor of economy. So they had been given the topic beforehand in the morning, so they had their ample time. But still, it's the prerogative of the honorable judges how they do it. But as we have given 10 minutes prep time to both the teams from Dubai Medical College as well as King Edward's, the equal time or the same time for preparation. So I suppose that is fair for them. But as you know, ma'am, as on an online session, it is it's inconvenient for people just to wait and hang on for so long. So that is why we have kept the prep time a bit shorter, and we had announced the topic early in the morning.
Yeah, thank you. Thank you.
You are welcome. Thank you so much, ma'am. So can I have all the participants on board, because we will be starting the final session of the debate in a minute. So do I have all the participants on board?
Yes.
So Assalamu alaikum, everyone. Hope everyone out there is doing fine. To all the judges and participants, Assalamu alaikum, and a very warm welcome to all of you. I'm Danish Ali Khan, and I'm doing as the General Secretary of Debates Club, Khyber Medical College, Peshawar. And I'll be moderating the final round of today's debate. So the finalists for the final round, as announced earlier, are the Team B from Dubai Medical College and Team A from King Edward's Medical College. And Team B from Dubai Medical College will be going in favor of health, and Team A from King Edward's Medical University will be going in favor of economy. And the topic for today's final round of debate is COVID-19 pandemic lockdown, health versus economy. So the motion of today's debate is about a very perplexing question, and that is if health or economy carries more significance in the current scenario of the COVID-19 pandemic. So Team B from Dubai Medical College will be defending health, and Team A from King Edward's Medical University will be defending the economy perspective. So the rules for today's debate, the final round of the debates, I'll go through them shortly. So number one, two teams of 4 each, 2 minutes introductory talk from each side, and then 3 minutes per member for presentation for and against, with 2.5 minutes cross-examination in between, then 10 minutes fire round and 4 minutes of conclusion. So it makes a total of 53 minutes. Rule number two, speakers are not allowed to go beyond time, and their microphone will be cut off at exact 3 minutes time. They must wrap up within their 3 minutes. We will run a poll-based timer to track time. Speakers can also use their own stopwatch. Rule number three, judges will score everyone independently, and there is no cross-discussion allowed as per the consensus between two debating societies competing today. The scores will be tailed for a simple total and announced as percentage for the team as a whole. There will be no individual member score. Now coming towards the introduction of the session chair and co-chair. So we have with us Honorable Professor Muhammad Waqar Azim, who will be chairing the final round of today's debate, and serves also the co-chair of APPNA Merit Program, and he's the currently professor at Sidra Medicine and Weill Cornell Medical College, Doha, Qatar. And we have our co-chair with us, and he is Honorable Dr. Yusuf Harun Ahmed, and he is the chair of Australian Association of Pakistani Physicians. And let me introduce the rest of the judges. So we have Dr. Majid Gondal with us. He's the president of Australian Association of Pakistani Physicians. So we are pleased to have you with us. We also have Dr. Muhammad Arshad Hussain. He's also a member of Australian Association of Pakistani Physicians. So we are pleased to have you with us. We also have Ma'am Laila Amir Lalji, and she's a freelance nursing consultant and a former faculty of Aga Khan University, Karachi, Pakistan. We also have with us Dr. Khizr Ashraf, and he is also a member of Australian Association of Pakistani Physicians. And at last, we have Dr. Mohsin Zaman with us, and he is the head of Department of Acute Medicine at Northampton General Hospital, United Kingdom. So officially starting the debate, I would like to invite the introductory speaker from Team B, that is Dubai Medical College, to please have the floor. And the individual speaker time for this speaker is 2 minutes. So can we have the introductory speaker from Team B, Dubai Medical College?
Yes, I'm here.
Okay, please start.
Can I begin?
Yes, you can begin. You can start.
We are living in the time of a public health emergency. Shops are closed, our identities hidden behind a mask, and our lives impacted forever. A very warm welcome to one and all present here. When I talk about the year 2020, most people will agree that the COVID-19 pandemic has proved to affect the quality of life in some way or the other. My team believes that COVID-19 has had a greater and a massive negative impact on the health of individuals. Prioritizing economy at this time can lead to the wiping away of humanity entirely. The death toll of COVID-19 is already exceeding 649K globally. Without any lockdown or social distancing measures, we can expect peak mortality in approximately 3 months. In this scenario, 81% of the United Kingdom and United States population would be infected, with 510,000 dying in the UK and 2.2 million dying in the US. How can we as medical professionals not advocate for health? Another point to be considered is that without a lockdown, schools will be open. Children in public health are considered to be one of the most vulnerable groups, and due to the lack of hygiene children practice, this may accelerate the rate of spreading of the COVID-19. Now let me ask my valuable opponents, what makes them think that it is right to allow infection to spread among the elderly who are a high-risk group by not permitting a lockdown? In a hypothetical case where economy may even flourish, if every individual is sick, who will enjoy the benefits of this flourishing economy? With this, I would like to rest my case and say that my team believes that health should be made the priority while dealing with the COVID-19 pandemic and not the economy, which can be revived at any time. Thank you.
Thank you so much, Fatima. Now, can we have the introductory speaker from Team A of King Edward's Medical University? The individual speaker time is 2 minutes.
Am I audible?
You are.
Yes, you're audible. Please continue.
So starting with today's notion, COVID-19 lockdown versus economy. Coronavirus disease 19 or COVID-19 is an infectious disease caused by severe acute respiratory syndrome coronavirus 2. The first case was identified in December 2019 in Wuhan, China, and has since resulted in an ongoing pandemic. The virus is fatal and has resulted in a lot of casualties around the world. No confirmed treatment is yet available to treat the condition, and precautionary measures are the only way to combat this disease. Multiple lockdown strategies have been employed by different nations to deal with this pandemic. Let me clear, we are not neglecting the coronavirus crisis, but we are saying that it is not the only crisis we are suffering from. Due to the COVID-19 pandemic, shutting down of trade and many businesses has caused poverty among the masses, and it has increased the crime rate and hostility. Daily wagers and those people which have to support their families by earning small amounts of money and do not have the mass stores of cash like the rich segments of the society cannot support their families in the same way as they do. So they will be the most affected ones, and it will be very much difficult for them to deal with the crisis without earning on a regular basis. Our principle suggests that coronavirus spread should be countered with strict following of SOPs while continuing the economic activities which are crucial for the survival of people. We regret imposing a complete lockdown on the public and not allowing them to perform their money-earning jobs, which is very crucial for the survival and survival of the poor and lower segments of society. Thank you.
Okay, thank you so much, Abdullah. Now, can we have the first affirmative speaker from Team B of Dubai Medical College? The individual speaker time is 3 minutes. So the floor is yours.
Speaking as the first affirmative, my name is Rihab Farouk, and I will be speaking in favor of health. COVID-19 is more infectious than other coronaviruses such as the SARS or MERS. The case fatality rate or risk of dying from the new coronavirus is about 4.4%. If COVID-19 is less deadly than previous epidemic threats, why has it spread so far and wide that it has brought the world to a standstill? The transmission rates, which have shown a vertical upslope, would then have exponentially increased with alarming consequences of a severe disease burden and high mortality. Experts say that social distancing can save lives, and a lockdown is an extreme version of social distancing. The fewer people who get infected, the fewer people they can go on to infect, and so on. Coronavirus is very, very infectious indeed. Every person can pass it on to three. If each of those three passes it on to three further, and that happens in 10 layers, one person would have been responsible for infecting 59,000 people. The greatest proof that we need a lockdown lies in the fact that every country on the face of this earth, with the exception of a very few, have imposed a lockdown at some level or the other. As of April 12th, nearly 90% of the population were under some form of lockdown. The lockdown has actually proven to display many other benefits. The levels of air pollution and warming gases have fallen in many cities and regions around the world where the coronavirus pandemic has spread. Moreover, people have started realizing the importance of technology. We have now realized that so many affairs that previously could not be held on the online platform can now be done so. If we take the example of New Zealand, the country imposed a lockdown by March 25, and when the number of cases rose by nearly 50%. And today, New Zealand stands as the first country to have declared itself coronavirus free. The light at the end of this tortuous journey is the development of herd immunity or an effective vaccine, or preferably both. As these are more than a few months, if not a year away, we may see multiple surge patterns. Any populist posturing at this crucial phase would have conceded the battleground in our fight against COVID-19. Honorable judges and dear audience, yes, a lockdown is the only solution. A lockdown on the cost of economy is the only solution. Thank you.
So the individual speaker time was 2 minutes and 55 seconds. Now I would like to call the first negative speaker for cross-examination. The individual speaker time is 2.5 minutes.
Am I audible?
Yes, you're audible. Please carry on.
Okay, the first question I'd like to ask from Team Opposition today, that you talk about imposing lockdown, but you don't talk about the possible time which you think that should be that lockdown should be imposed for, because because the corona pandemic is something that is going to stay, and when you're going to impose a lockdown for such a considerable period of time for so long, there are so many other problems that are going to arise because of it, and how do you cater to all those problems then? So these are two questions that I'm asking you: the possible time that you impose a lockdown for, and how do you cater to the problems that arise because of it? Because then according to your model, you have to impose that lockdown until or unless a vaccine is available for corona. So deal to the questions.
Actually, if we look at the statements by the WHO and many other pharmaceutical industries, the vaccine is not very far away. Many countries have indeed reached phase 3 of clinical trials. The population at this point needs to be a bit more patient. They need to support their governments for a while more, because hope is not far away. In terms of your second question, that how do we cater to problems? I would like to ask you that how would you cater to the problems, to the health impact that will arise if we do not impose a lockdown?
Okay. We believe that this coronavirus, even when the vaccine is going to come, you are yourself admitting that the vaccine is in the third phase of testing. Even when the vaccine is going to be available, even if it's not, now we have seen that many people, they have developed immunity against this coronavirus, and to some extent, to a lot of extent, people are recovering. In fact, Pakistan has the highest rate of recovery of patients suffering from this virus. So, but poverty, hunger, unemployment, they're all crises which we believe are going to create more death rate. They're going to create a greater death rate as compared to this corona pandemic when you're going to impose this lockdown for so long.
I would like to answer that by saying that can you provide any statistics that support that that deaths out of poverty are greater or more burdening on the economy than the deaths out of coronavirus?
The I can prove to you because these deaths. Yes, complete your question.
The deaths resulting from coronavirus are exactly the cause why the economies are collapsing. In order to fix the economies, in order to rise once again, we need to first control the pandemic.
We are done with the cross examination time. I would like to call the first negative speaker from Team A, King Edwards, for his speech. Individual speaker time is 3 minutes. Can we have the first negative speaker from King Edwards? Individual speaker time is 3 minutes.
Yes, I'm here. Yes, I'm here.
Okay, please carry on.
Okay. As team proposition, the main stance that we take today is that coronavirus, we do believe that coronavirus, that is a potential threat to individuals who are to individuals and to the life of so many people, and this is a global pandemic. But there have been other crises existing along with this coronavirus as well. The hunger, poverty, unemployment, they're killing more people than the corona pandemic. So the main line of argument that I tell you today is this, that the coronavirus, it is going to stay unless or until a vaccine is not available. This virus is going to stay, and that the lockdown cannot be the ultimate solution to it. And what we demand from team opposition today is a more viable solution that they present to us today. Okay, so since we believe that the corona pandemic, this virus is going to stay, there is always going to be a sudden limit, a specific limit to stopping the a specific limit to the imposing of lockdown as well. Therefore, what we need to do is we need to follow a more balanced approach, because lockdown is not going to solve our problems today. For this, the way forward, the ultimate way forward, we believe, we are going to adopt the people, they need to adopt SOPs, the proper SOPs, and then they can continue their professional lives as well. Now, we believe that even when individuals there's so many individuals who are working on daily wages. They are being paid like 6,000 or 7,000 rupees a month, and when you're firing so many individuals due to the economic downfall that results because of this pandemic, these individuals are ultimately going to die of poverty as well. So we have these statistics as well. Okay. In the first employment report, after social distancing measures had taken hold in many US states, the Department of Labor announced that 3.3 million people had filed jobless claims. A week later, in the first week in April, an additional 6.6 million claims came in, and these are almost unfathomable compared with the previous record of 695,000, which was set in 1962. So you have to cater to all these problems that arise because of the pandemic as well. Also, we believe that even if individuals, a very limited number of companies, they have this preemptively established online programs, and they can work while sitting at their homes. While so many laborers which work in factories, they're working in factories and they cannot work from their home. A daily wage worker, he ultimately has to go out, he has to earn, and he has to bring food, sustenance for his family, because at the end of the day, only he is responsible for providing sustenance to all of his family. And when we are imposing a lockdown, we are not only putting the life of that particular individual threat, but we are putting the life of so many individuals who are dependable on him on threat as well. Thank you.
Okay, thank you so much. Now I would like to give the floor to the first affirmative speaker from Team B for 2.5 minutes of cross-examination.
Dear opponent, you presented the idea of following SOPs instead of imposing a lockdown. I would like to remind you that the lack of education and awareness of the public is exactly why we need a lockdown. The example you gave of Pakistan being the country with the highest recovery rates, Let me remind you that it is the very country that denied the existence of coronavirus, calling it a propaganda. Are you, with this level of education of the public, that they are denying the existence of a disease that is killing hundreds and millions of people around the world, then what SOPs are we expecting them to follow? A lockdown by the government is a harsh way, as it may sound, but it really is the only solution. What do you have to say about that?
Okay. The first point that you discussed was how do we treat the unawareness in people. So I think that people need to be aware more when we are going to approach. That is something we need to treat rather than not by imposing a lockdown. We are going to treat it on some other level. Um, because that we do not find is suitable. What was your other question? I just forgot it.
My question was just this, which you haven't been able to answer to, is that the lack of education and awareness does not help us, does not make SOPs the only solution. We indeed need a lockdown. Furthermore, I will move on to my next question, which you said was that there's a lot of hunger, there's a lot of unemployment, there's a lot of poverty. Now, dear opponent, aren't you aware that if you have recognized these issues, then the world leaders on the top fronts have recognized it before you? And they, more than in fact, not half, in fact, the entire world population, the entire number of the countries around the world have been under a lockdown. Now, when all
firstly,
those...
let me answer. I won't have time to answer then. Firstly, I think that people have been aware enough.
You just have 10 to 15 seconds left. So please finish
Firstly, I believe
within that
that
time.
people have been aware enough to treat themselves as home as well. Secondly, you can not deny the fact that when you're imposing a lockdown, there's going to be a lot of backlash from the traders and from the general public as well. So how do you cater to that backlash that arises because of it?
So your time is up. Your time is up. So I would like to give the floor to the second affirmative speaker from Team B, Dubai Medical College. The individual speaker time is 3 minutes.
Okay.
Can we have the second affirmative speaker from Dubai Medical College?
Yes, can you hear me?
Yes, please carry on.
Okay. I would label the position of favoring financial gains over human health a form of exploitation, a purposeful exploitation of humans to a virus that has shown to cause long-term detrimental effects in some patients and proven to be fatal with its death toll exceeding 649,000 globally. Referring and reiterating what my colleague Rihab has already gone over, looking at what is now dubbed a role model in swift control and action with regards to this pandemic, New Zealand. Recently, it has reported a total of 0 new cases. This is due to the lockdown imposed on civilians and strict control of movement. When prioritizing health over financial gains, it can be observed that the economical benefits will follow. For instance, now citizens can freely go out and invest their wealth back into the economy. Medical bills that often leave civilians struggling in debt will no longer be a concern. Jobs have resumed to the most of their capacities, facilitating the swift return of what was once normal life. A pandemic can impact an economy in many ways, even without public health policies. Reductions in people's willingness to work, dislocations in consumption patterns, and lower consumption in general due to fear of financial uncertainty. And this is what we know as the supply shocks. It includes labor supply shocks, financial supply shocks, etc. And through this theory, we understand that the existence of a solid economy is dependent on the creation of adequate testing, treatment, and quarantine, i.e. adequate health. Undermining this health emergency is not only contrary to our stance and assessments as doctors, but also serves to reveal a deeper problem rooted within our society. When was financial gain superior to preventable diseases and death? States such as Florida, California, and Texas are all now reporting a large number of infected cases, this arising after they have lifted the quarantine rule. a real life example of what disasters could arise, both medically and economically, to a country. It is important to note that the debate we are undertaking is one that is crucial as we near the winter season, where the survival of the virus increases significantly and the severity of the pandemic will spike, where the BBC reported that a second wave in winter could lead to the death of 120,000 in the UK alone. Finally, taking the side of the financial burden will cause the creation of a vicious cycle, where the little financial gain created will be counterintuitive to the extensive cost of treatments present for the continued prevalence of cases. I end with a quote from Mahatma Gandhi: "It is health that is real wealth, and not pieces of gold and silver." Thank you.
Okay, thank you so much. One more thing I would like to add here: if while doing the cross-examination, the speaker must ask questions within 15 to 20 seconds so that the other speaker also get time to answer that. So please keep that in mind. Now I would like to invite the second negative speaker for 2.5 minutes of cross-examination. So can we have the second negative speaker from King Edwards?
Yes, I'm here.
Yes, please carry on.
Can you please answer me that your little financial gains that you're describing, the little economy, is the one that is supporting all the healthcare and the hospitals and all the treatment that has been taking place in the hospitals is
I'm
due to
sorry, I cannot hear
that
you.
economic budget?
I'm sorry, your
Should I
voice is
start
cutting.
again?
Yes, please. You said the little financial gains and then you got cut off.
That little financial gains that you're describing, that is the same economy that has been fueling all the healthcare and hospital and all the treatment facilities that this corona pandemic patients needed. So how do you explain with that?
Okay, I'm sorry, some of it got cut out. So you were saying like the little economic benefit is the same as the impact by the coronavirus. I didn't really understand that.
No, I'm saying hear me now.
One second. Okay, I can hear you. Go ahead.
Okay, I was saying that the little economy that you're describing is the one that has been fueling all the healthcare and hospitals and all the treatment that the coronavirus patients are undergoing in these such facilities. It is due to that economy and that budget. How do you answer that?
Okay, so you mean the current, treatment being done in hospitals is due to this little financial gain, right? Is that what you're
Due to the
saying?
economy, due to the financial funding of these facilities, because you're neglecting
Yes.
economy at all.
But you see, let's talk about it this way. The current treatment of these patients within the ICUs and whatnot within the hospitals is not really due to the current spending of civilians, purchasing, in shopping malls or the workforce being done. It is actually the money that was previously within the state from the previous sort of like the pre-corona pandemic earnings. And that money that is being used to run the hospitals and the treatments is what's funding it, not necessarily the little the little financial gains done if certain civilians go out and purchase or they work. Because as we can see right now from reports that we are suffering perhaps is I think 0.3 to 0.6 decrease in the overall global world economy by the end of this year. And so no, it's not necessarily the little financial gains, because as I mentioned in my speech as well,
Your time is up. The time for cross-examination is up. So I would like to call second negative speaker from King Edwards to please have the floor and deliver his speech for 3 minutes. The individual
Okay,
speaker
here
time
I
is 3 minutes.
Let me start. So the fellows described that there were many deaths. There were so many numbers. They were showing up from the Wikipedia page they have recently read. So I would say that we as Prof have been questioning the cause of the death. That was the awareness. So basically we believe that when we are going to enforce something, it means that we were unable to convince anybody. And in this case, we were unable to convince our population. Some governments were unable to convince their populations that this is a pandemic that should be seriously dealt with the SOPs. That's why they have to go to the force and such things that are obviously improper, because this is their failure that they could not, they should have properly. Secondly, education and awareness are two different things. We believe that even if a person does not have education, then this doesn't mean he can't wear a mask or he can't be aware of the disease, he can't take care of himself. We believe that lockdown is not a solution. Just in case of Sweden, we see that there has been a drop in the cases without ever having a lockdown, because the governments were able to convince the people that they should have to follow the SOPs, and that is the ultimate goal that we have to achieve. Is that the such pandemics that are obviously going to be there again and again. There is a coronavirus, there can be another. When then the lockdown no longer remains a solution. Secondly, they pointed out that we can work at home then with better facility. Then we believe that in the third world countries there are not that much facilities to work online or anything such that. And even if someone is going to be have such a system, then they need to buy or pay for this. And then I would come to my positive case, is that sitting in an air conditioned room with all the facilities, we talk of imposing lockdown on the people, especially in the developing countries who are totally dependent on their daily wages. They do not have any source of earning other than that, especially the manual labor and such things as that. Now we see that how much effect it causes. Some people were affected by coronavirus, while the total lockdown on the whole country imposed a large number of unemployment. 140 million people in India lost jobs, and the world global growth falls by -3%. This means that even if you don't have a job, this doesn't mean that you die all the time. Although 1% unemployment goes up, 40,000 people die according to the Economic Forum report of 2011. But your life becomes miserable. Just imagine that you won't get the payment, you won't get the money, especially if in case of private job. What aggression, what depression would it cause? What can you not for your job's sake, can you not follow the SOPs? If you're said that if you don't follow these SOPs, you will be imposed under lockdown, then one obviously goes for not going through the economic loss, but following the SOPs. That is the ultimate solution of the coronavirus. Because all said that lockdown, she said that lockdown is for social distancing, but social distancing can be maintained without even a lockdown, just as in Sweden we have given as an example. Then we
Sarmad,
see
your
that
time is
the
up.
firing,
Sarmad,
just one
your
point, the
time is
firing
up.
of the people from the seats starts with the very basic ones that are obviously manual labor, because that are the first level of firing someone away from this thing. An economy that has taken hundreds of years to develop, you cannot
Sarmad, you
lose
are
in
going
just
over
one pandemic, because we are going to have
overboard. You will be
pandemics
given
again and
negative
again.
marks
Thank
for that. Okay, so the individual speaker time was 3 minutes and 10 seconds. Now, can we have the second affirmative speaker for 2.5 minutes of cross examination?
Okay, firstly, I would like to ask the speaker whether the speaker is suggesting by his statement that it is due to the government's inability to convince civilians to social distance, wear masks, etc. Is he suggesting that civilians can do as they please without any legislation in place?
they can do when they are you can say they are made aware of this, even not educated or nothing. When they know that there is a pandemic, they have to deal with it, then they can do better for it. We are saying that. And just we give the examples of some of the unemployment people. Just you see as another example that accidents kill much more people than this coronavirus has still now killed. Then does this mean that we ask everyone to stop traveling on the roads? Instead, we ask them to follow the traveling rules and the road rules and such things that can ultimately prevent any accident, instead of asking them to go into a lockdown, sit in their homes without any jobs and something like that.
So unfortunately, perhaps in an ideal world, you could apply your theory, but in reality, that is not the case. Civilians are doing as they please in states such as Florida and California and Texas, as I mentioned. They are not remaining at home, not abiding by the quarantine laws imposed, and they are now not wearing masks, they are not social distancing, and that is why we're witnessing a large spike in the number of cases. It is
Should I answer
frightening
it?
in all actuality, and it is because this idea that we let civilians do as they please so long as they understand. No,
No,
civilians do not
let
fully
me
comprehend many things, and so for their own protection, we place
Actually,
laws
in the
such as
states you
the
have
quarantine
been
and
talk.
the quarantine, so that we prevent any form of disease.
May I
Because
answer?
perhaps it is 1 second, please. Perhaps before,
It's so
because
long question, please.
it wasn't a question; it was actually a response to your statement that was incorrect. But yeah, go ahead. What would you like to add?
The stage you're talking about, obviously there was a huge backlash from the public in that areas, and people were not following those SOPs, claiming it to be the avenge on their government for making them lose their jobs, making them confined to their homes, making them into such a strict lockdown. That was the main objective for those people not
Ahmed, your
following
time is up.
SOPs on
Your,
that.
your time is up. You're going overboard.
It
So
was a
we
very
are done
large,
with the we are
not
done with
of 20
the
seconds.
examination. Uh, I guess you are done with your time. You'll get negative marks, so your rest of your teammates can just make it clear in this. So can we have the third affirmative speaker from the Team B of Dubai Medical College? For her speech, her individual speaker time is 3 minutes.
Okay. Remember the famous quote, when wealth is lost, something is lost. When health is lost, everything is lost. A very welcome to all. The opposite team may urge to reopen the economies and lift the restrictions, but let me ask you, if you have no healthy person left behind, who is going to run your economy? With no vaccine or cure in sight just yet, imposing restrictions have been the only way, besides testing the population, to curb the spread of the disease. The purpose of a lockdown, as explained by a study from Imperial College in London, is to reduce reproduction. In other words, to reduce the number of people each confirmed case infects. This study model shows that as painful as lockdown may be, it works for many of us. Without any lockdown or social distancing measures, we can expect peak mortality in approximately 3 months. In this scenario, 81% of population of UK and US would be infected, with over 5 million people dying. In a study conducted titled Impact of Non-Pharmaceutical Interventions to Reduce COVID Mortality, it was hence researched and concluded that it was suppression of regular activities that not only saved life, it also helped to slow down the effects of the pandemic significantly. Another study titled Lockdown Timing and Efficacy in Controlling COVID, done in Italy, it was also proven imposed lockdowns were followed by a peak and then reduction in cases. It is important to understand our stance that by supporting health issues of COVID, we're not only redirecting our energies into better way of implementation of lockdown, but to also focus more and more on testing, making PPE suits available, and using our funds to develop vaccines and drug trials, and even investing in technologies to smoothly transition to opening up these lockdowns. To conclude, I'd like to say this is the time we focus. This is the time our focus should be directed on saving lives and containing the virus so that we may recover and go back to our economies faster.
Okay, so can we have the third negative speaker for cross-examination of 2.5 minutes? Rafiq, are you done with your speech? You're still left with 1 minute. If you're done, we can just move on to the cross-examination.
I think I would like to go to the cross-examination because I'm done with my speech.
Okay, so please, Abdullah Ilyas, continue with the cross-examination.
Okay, so first question, when you're talking about lockdown being the ultimate way of countering coronavirus, the only example you come up with is New Zealand, a country with 5 million population, 99% literacy rate, a highly well-developed economy, and even after their immense imposition of lockdown, as of 27th July, there were 1,236 active cases of coronavirus that got regenerated or got resurfaced in New Zealand. Apart from New Zealand, you have absolutely no other authentic example to support your argument. First question. You want to answer it right now, or I should proceed with my questions?
Yes, I would like to answer that.
Answer.
Actually, you may be misinformed because Sweden is an example that I would like to quote where no lockdown policy was adopted. And as of July 2nd, Sweden's prime minister had to order an inquiry after thousands of COVID cases were reported in the country because of this no lockdown. Do you really think that while people are dying, economy should be the focus? It should be the focus for sure, but it should only be the focus after we have tackled these cases.
The idea I'm trying the point I'm trying to make is that your idea of a perfect lockdown being imposed and leading to a very healthy societal atmosphere without coronavirus, that only applies to countries like New Zealand with very small population. In countries who are struggling with economy, in developing countries and where there are already crises of hunger, poverty, etc., etc., the idea of a lockdown does not bear good results. And but that's my response to your answer. In addition to that, the second question I want to ask is, what is the exact limit of your lockdown? Do you want a country to be under lockdown for 1 minute, 2 minutes, 2 months, 3 months, or even a year for that matter? Because when you're talking about vaccine coming up and only then you are supposed to be uplifting the lockdown, vaccine takes months and even perhaps years to be established and then distributed across the world in developing countries and in a lot of ways. So you have absolutely no tentative, even a tentative date to suggest that a vaccine will be available and can be provided across the globe. So you cannot possibly expect us to believe that you say that a lockdown is supposed to be implemented and each and every person across the globe is supposed to live in their homes until unless and a vaccine is made and then it is distributed across the globe. Please answer.
Yes, I would like to answer using the example of UAE. So now UAE, the restrictions were imposed until the peak was reached, and the ease of restrictions were made. And after the peak was reached and the cases started to decline, and only after that the energy was redirected to reopening the economy. What you must understand is that not all is lost. If our economies are currently at a
The
low
time
because a
for
lot of companies have
cross-examination is
switched to.
up.
Okay.
If you can please hear me, the time for cross-examination is up. I'd like to give the floor to the third negative speaker from King Edwards. The individual speaker time is 3 minutes.
Okay, so one question that was left, and that was that if we have the resources to enforce lockdown, why don't we have the resources to enforce SOPs? And that is something we believe we can impose in a model. And I'd like that to be answered by the proposition here tonight. Now, coming to my positive argument, the impracticality of the model presented by the proposition is what exactly beguiles me. And they come up with fancy quotes about health being everything and wealth being nothing. You can come up with that, and you cannot practically apply it to the real world. When you're talking about countries in general, when you're talking the global world out there, you need to understand that there are innumerable developing countries out there, countries that struggle economically, in which people struggle economically where they struggle real hard to provide themselves and their family members a shelter and food and whatnot, and they live in very poor health conditions ordinarily as well. So you need to understand that their idea can only be applied maybe to like the topmost 2% of the people like Jeff Bezos, the owner of Amazon, where they actually flourish in conditions like these. The other people, and starting from the bottom, the low tier people, they actually suffer it. Now, my positive argument stands with this, that economy is directly linked to a lot of other things. So when you're talking about imposing a lockdown and focusing on your health conditions, you need to understand that in order for your health system to run in the first place, you need a lot of financial stability for that matter. That may be the case in case of developed countries. For developing countries, in order to sustain the continuing health system and the funding into it, you need to have a proper import system. You need to have economic activities going in order to generate revenue, in order to invest into the healthcare facilities. So if you talk about lockdown for a couple of months, probably even a month for that matter, developing countries cannot sustain your own healthcare system that is supposed to counter coronavirus pandemic if they impose ultimate lockdown. More than that, you need to understand that poor economic conditions, there are a lot of problems that arise. Health problems also arise out of poor economic conditions. So if you have people who cannot afford even going to even getting health insurances or healthcare because of their poor financial stability, you'll also lead to a spike in cases of health conditions, health problems other than the coronavirus, something that you fail to understand. You need an example. Yemen is a great example for that. African countries are a great example of that, where things do spike after it. The other idea is that when you're talking about economy, When you're talking about shutting people and depriving them of their financial stability, you talk about an increase in crime rate. And you've seen that in a lot of countries. You've seen that in Pakistan. You've seen that in a lot of issues, and in a lot of developing countries, because of the fact that in the third world countries you have people who, at the end of the day, if a person is in his or her house and he is not supposed, he's starving, his children are starving to death, and he's not supposed to go out and earn money for his or own children, simply because of the fact that he might get coronavirus, he'll get out and he start killing people and robbing people in order to serve his or her family. You need to understand that. You need to get out of that elitist mentality if you need to ensure that your model is applicable to everyone across the globe and is viable and is balanced in keeping in view the great factions across the world. Now you need to understand one other thing. The idea that backlash is, if you impose a lockdown and force people to live within, the idea is of backlash, and that backlash is very reasonable given the financial constraints of the people. You saw that in Pakistan, you saw that in countries, even countries as developed as United States, America, where people got out of their homes, got into processions and protests. When you allow, as a result of the reaction to lockdown, you
Abdullah, your time is up. Your time is up. You are done with your 3 minutes. Now I'd like to call the third affirmative speaker from Dubai Medical College for cross-examination.
All right. So my first point would be, I think the opposite team should realize that by talking about saving lives, we are not maintaining an elitist mentality. Rather, we are having a very humane approach. However, my question to you would be, in a business journal published titled COVID-19 Risks to Migrant Workers, they themselves explained how workforce is very sensitive to getting
if he or she
infected
has
with
that threat in
COVID
his mind,
while
if he or she has that
working.
in his mind, he can very easily. Did were you able to hear me?
Yes, yes, please carry on.
So as a result of your own model, more people will die of poverty, more people will die out of
Abdullah, please let her talk, because it's her share of cross-examination.
I can't hear whoever is speaking. If Tarab is speaking, I can't hear her.
So let her ask her question.
I can't hear her. I'm silent. I'm waiting for her to speak.
I think you need to draw her attention that she cannot be heard.
Tarab, I cannot hear you. If you're the one speaking, I cannot hear you right now.
Tarab has had some connection issues. She will be joining in a few seconds.
Okay, I'm waiting. Meanwhile, should I continue or not?
No, she's
Abdullah, we can start over again for the cross-examination. So, are you with us?
I just want to clarify. My speech ended. Everyone could hear. Tarab was able to hear my entire speech.
Yeah,
Abdullah, you were audible at that time, but I guess there's some connectivity issue with Tarab Iqbal. So let us just solve that issue, and we can just continue after that.
Hello, am I audible? Sorry?
Yes,
Tarab, you're audible now. Tarab, please carry on.
All right. So my question to you was, you were talking about, you are being the voice of the workforce, and that is great. However, you need to understand that in a business journal itself, it was published how the workforce is very sensitive to getting infected with COVID. In fact, workers themselves have reported that they fear getting infected with COVID, and that would prevent them from coming to job. How do you respond to that?
Okay. First, you need to understand that the mortality rate of coronavirus is very less. Is almost near about 1%. Most of the people who get infected by coronavirus do get recovered. Nonetheless, my question to you is very simple. So there is this off chance that a person who might get out and go out to earn money for his family and his children, he might get infected. That there's a very less probability that he does. Even if he does, there's an even less probability that he dies out of it. And the other is a sure possibility that if he remains within his house and he is fired and he is unable to earn even a single penny for his house, their family will suffer and probably will die out of shortage of food and other things. There will be reaction on his part because of his financial instability, such as crime rate increase, such as protest processions. What will you do then?
Okay, then I can ask the same question to you. So should the person, or should we open up offices and workspaces and people over there start getting infected? What would you do? Would you not force them to go into quarantine? Essentially,
Exactly the
you are
point
still
I'm
impairing their
suggesting.
economic
You need
productivity.
to Okay, so at this point, what we do believe, know as a matter of fact, that coronavirus is a contagious thing, but it has certain level of SOPs which, if enforced, can be can stop the spread of coronavirus if SOPs are imposed, right? The idea is that you impose those as SOPs, because you need to understand that yes, coronavirus is a potential threat, but it is not the only crisis that the world is facing right now. And in order to treat or cure a crisis, you cannot make measures that inevitably and undoubtedly lead to the exacerbation of several other crises, which inevitably affects millions of people, especially those people who are already the less privileged ones.
We are done with the cross-examination time. Now we move on to the rapid fire round, and the total duration of this round is 10 minutes. And I would request both the participants from the two teams who are participating in the rapid fire round that please get your share of time and also let the opponent speak, because we have 10 minutes. So you both are requested to please get your share of time and let the other speaker speak too. So can we have the speakers from the rapid fire round from both the teams?
Sir, if I may request one thing, firstly, the proposition can ask questions from the opposition, and that question session can last for like 5 minutes. So after 5 minutes, let us know, and then we'll switch the role. So after 5 minutes, the opposition will start asking questions to the proposition, if that's okay.
If that is okay with the Dubai Medical College team, so there's no issue. If you want the government or the proposition to speak for 5 minutes, and then you want to speak for 5 minutes, so we are good to go if both teams are okay with that.
More of misery. And
Your mic is muted. Walid, if you can please unmute Fatima Mariam from Dubai Medical College.
Sure. Rehab, can you please respond?
Yes. Just give us a minute, please. We will discuss this and let you know.
Okay.
Because actually the essential purpose of a rapid fire was not to limit the speakers to question and answers, rather to give them an open, fair amount of chance to do it however they want to do it.
Danish, this is Professor Azim. I will suggest just follow the rules, what was put in before. Just follow the rules.
Okay.
Fine,
Okay.
let us follow the previous
teams. Yes, you please follow the already decided format. So we cannot change the format just at the moment, just as Professor Vakar said. So we just have to carry on with the already decided format.
Okay, so the rapid fire speakers from our university is Tarab and myself. We will be starting, and the first point, Danish, is the time started, right? I can begin?
Yes, you can begin. Please continue.
Okay, so the first point I want to put forward was something that one of the opposition team members said about the fact that education and awareness is not a factor that determines whether people can adhere to SOPs. And they said that a person can put on a mask if he is told so. Moreover, they gave the example of Sweden as a country that has implemented SOPs without the need of lockdown. Now comparing these two statements, I would like to ask the opposite team that can you compare the literacy rate of Sweden versus the literacy rate of Pakistan that you have been bringing up as an example? The literacy rate of Sweden is much higher. And that is exactly why they have been able to, at some level of the other, control the pandemic and explain to the population the need of SOPs, while Pakistan has failed to do so.
as is the case with many third world countries. So how can you make the statement that education is not a factor that is determining how well people can adhere to the SOPs and the lockdown?
Abdullah Ilyas, can you please respond? Or the rapid fire members from the King Edwards?
If there's no response, I can go on with another point.
Abdullah bhai, may I respond?
Yes, please carry on.
Okay, now you should realize that there are two things: lockdown and SOPs. We believe that SOPs are probably much more important than the lockdown, as we see in Pakistan, where even lockdown were imposed. People were not ready to accept the disease as real, and as a result, they didn't follow any SOPs. So even if you put them in your homes, put all the lockdown.
I think we should stop because Abdullah Ilyas is not, he's unable to hear all of us. I think we should wait for him.
Okay,
May I
Waleed, can you
complete my
please?
point?
Now, can anyone hear me now?
Yes, Abdullah Ilyas, you're audible now.
Sorry, I got disconnected for a moment. I'm back. You guys can continue now.
Okay.
May I complete my point now?
Yes, sir.
Yes,
You can
please continue.
We were talking about lockdown and SOPs. In Pakistan, we see that even if lockdown was imposed, people were not ready to follow the SOPs because they did not think the disease was real. Government was unable to convince them the severity of the disease. If they had been done that, then we would not probably need. If they had done this, then the situation would have been different. If people follow SOPs, then research has proved that going out following the SOPs cannot put anyone's life in danger, and in this way we can easily prevent coronavirus from happening. So I would put one question now from the other side, that we are taking both things together. We want to solve this crisis as well as preventing a very major economic crisis that has been an issue for hundreds of years, and because of this small crisis, we don't want to lose all of that. That's what we are pointing out. So you please tell us that how if economy, we do not care for the economy, what if another crisis takes place and another pandemic takes place, then what will we do? We will put another lockdown again?
Thank you,
To
Sarmad,
answer to
because
that,
you have exactly proved my point. Sarmad, you have exactly proved my point that the Pakistani people have not been able to impose SOPs in spite of the lockdown, which exactly comes back to the fact that there's a lack of education and awareness. And we have to realize that following rules, understanding the severity of the pandemic, and then adhering to it goes hand in hand with our imposing of the lockdown.
furthermore,
let me
I
answer
think
that.
I would like to add just.
If I can respond to Rehab's point, I'll get back to you, Rahab. The idea is very simple, that in case of Pakistan, even regardless of the literacy rate, even after there was a lockdown for a very short amount of time, and even after that the lockdown was uplifted and the peak was yet to be reached, and even after the uplifting of lockdown, there has been a considerable amount of SOP being followed, as a result of which currently Pakistan is almost is flattening the curve in a way, at an exponential rate. It is flattening the curve at an exponential rate even after uplifting the lockdown. And as a result of, while even countering the coronavirus, the additional benefit is that we are also able to cater to the economic conditions of the country. You need to understand that the literacy rate is irrelevant in this case, because people will come out to earn their bread. Now, in even countries like United States of America, where literacy rate is considerably better than Pakistan, you have had the same reaction to lockdown as there was in Pakistan. So you need to understand that literacy rate is irrelevant at this point of time. The people will come out, and the SOPs is the only way forward. And following SOPs has considerably allowed countries to cater to the coronavirus.
Abdullah, even after the uplifting of the lockdown, as you said, in Pakistan, I'm sure that you must be more aware than me, living in Pakistan, that it was only uplifted to be imposed once again within the duration of less than a month, as the country
witnessed the exponential rise in cases once the lockdown was lifted. And if I was to go on to name the cities that reimposed the lockdown, there is the example of a lot of areas in Lahore, a lot of areas in Karachi and Islamabad, which are considered one of the three main cities in the country. How would you respond to this?
Allow me to answer that. The perfect imposition of lockdown was only done in the entire country for 20 days from the third week of March to the first week of April. After that, the lockdown was lifted. And the point that you're making, it's a reference to our strategy called smart lockdown. So if there is a normal routine of life going on. So if in a particular town of Lahore, there is an exponential increase in the coronavirus, you seal that area. And that is a part of a very smart strategy while preserving economy. You need to understand that. And that is, by any means, after the first week of April, in Pakistan, lockdown was not implemented again, and we have successfully been able to flatten the curve.
So you have
to
by
add to
yourself
that,
called, Sarab, just 1 second and I will let you continue. So you have by yourself called lockdown a smart strategy. Thank you very much for that. Sarab, you can move on.
We have not called it.
No. Sarmad, let me answer. Rehab, you're horribly mistaken. Smart lockdown is an essentially different strategy than lockdown. I'm not calling the perfect lockdown a smart strategy. Smart lockdown is another term that is used for this concept, which was implemented in Pakistan in some areas, that if there is no lockdown in place right now, but if there is a particular town, there is an outbreak or an exponential increase in rate, you see that town only. That is the only thing that I'm calling
all
smart
right,
about.
but where are we advocating for a complete lockdown or a partial lockdown or a smart lockdown?
Might I just add that even in those cases, businesses were
Abdullah, you are
open.
going overboard. You have taken too much of time. Let Tarab speak if they have any concerns or questions so that you can answer
I
it.
took Tarab's point. I'm answering
I think
Tarab's
I'm
point.
not done yet, but you
Please
did
speak.
cut me
Please
off.
carry on.
I think the opposite team needs to understand when they are defending or when they are giving examples of smart lockdown, which is imposed in one part of one city, the idea is still of a lockdown. So you are still quoting our examples to justify your points. We are not here to talk about a nationwide lockdown or a citywide lockdown. We are talking about restrictions to be made from a health perspective, and then we can tackle problems of the economy.
Okay, understand this.
May I ask one thing just?
Sarmad, 1 second. Let me just clarify this. I am by no means supporting lockdown. Any confusion in this part is because of your lack of awareness of how smart lockdown works. Understand that even in smart lockdown, the business enterprises and economic activities were not stopped within that area. Only the flow of unnecessary traffic was checked within those towns. So even, let's say, in a small town called Faisal Town in Lahore, that was sealed, people within Faisal Town who had to go out for their economic activities and business enterprises were totally and at absolute liberty to do so. That's exactly our point. You need to, if there's any confusion here, it's only because of the fact that you're not aware of how smart lockdown works. I'm not at all supporting any idea of implementation of lockdown.
I think we're not against opening up countries and workplaces and allowing people to work. I think the idea is still to not allow a section of society or the entire society to not go out for a particular period of time. I think you are just going around and defending our point and making it stronger by saying that a certain section of the society were not allowed to go where others side. Yeah.
Let's move on to a different point because I feel like this. Sorry.
Can you all please hear me? We are done with the time for the rapid fire round. Now it's the turn for making concluding remarks from the team A of King Edward's Medical University. So can we have the concluding remarks from team A? And the speaker time is 2 minutes.
Am I audible?
Yes, you're audible. Please continue.
First, I would like to sum up the points which are made by the both teams. First of all, our first argument was that the vaccine is not coming soon. So lockdown is not the ultimate solution for the betterment of the situation. It will only lead to more deteriorating economic situation, which will lead to further more exponential problems. Secondly, we said that very limited number of companies provide work from home facilities, and the people which need to go out, such as laborers, to earn their daily wages, they cannot possibly work from home. And if you are saying that during this pandemic period, the expenses of people are reduced, even then staying at home, they have to pay the utility bills, they have to get tests for coronavirus, they have to get treatment. How do you possibly believe that they will be able to pay those expenses without earning any sort of money for them? Thirdly, we said that education and awareness are two different things, and people can still be aware to follow the SOPs and maintain their economic activities. Literacy rate is totally irrelevant in this aspect. Then we said that in the same way that they are talking that lockdown can be imposed and people can be restricted in their homes, we SOPs can also be implemented in the same way. People can be allowed to go to the specific work, and they can be made to follow the SOPs and do their economic activities, which will be better for maintenance of economy. The team proposition has given a lot of one-liners, and they haven't totally made any of their point. They haven't established the extent of the lockdown. They haven't told for how duration they want to maintain the lockdown, because the vaccine won't come for an indefinite period. They put forward an example of New Zealand, which was totally absurd, because New Zealand has a very low population and it is totally developed and has a high poverty rate. The government can totally support the people during the pandemic period, and because it is a developed country, which is not the case in developing countries. Just a second. And lastly, they have told that if the second wave is imminent and a high number of casualties are imminent, we cannot simply just restrict the people in their houses and deprive them of their only money earning sources. This will only lead more people dying of poverty and hunger than the coronavirus. So what their model totally lacked was that they failed to provide.
Can we have the concluding remarks from Team B of Dubai Medical College?
Yes. Am I audible?
If you're audible, please continue.
Okay. COVID-19 is a potential threat to humans beyond the extent to which we truly understand. How can we be humane and force people with other predisposing factors to risk their head and livelihood for the sake of economy? Does the opponent not believe that it is smarter to be safe in your homes than be sick in the ICU beds? The opponent is undermining the value of every single life. Let me remind you, media may often make human life look more about numbers and less about the people who have a life which they deserve to live. As medical health professionals, it is our responsibility to work for the betterment of the health of every individual whose life we can impact. The opponents kept giving examples of developing countries not being able to follow lockdowns. I would like to give them the example of India, which is a developing country, and applied a nationwide lockdown. An expert from the Indian Council of Medical Research adds that it is believed that COVID-19 infection can spread the virus to more than 400 people in 30 days. We cannot allow people who may have the virus to be roaming out openly in the country. I appeal to all of you to understand the gravity of this situation. In the absence of the lockdown, the virus will spread like wildfire. Is not one uniform. We have to keep in mind that the population is not one uniform block of adults. Instead, it is a block of children and old people. We cannot put these high-risk groups at a high risk. The other team kept bringing up SOPs. To respond to them, we do not have enough time to empower the entire population with these SOPs. It is easier for us to impose a lockdown and ensure the health of the community. They also brought up a point about migrant workers, for which we believe that it is the way to handle this situation is by providing incentives to these workers to stay at their homes, and we can definitely bring about a positive change by ensuring the lockdown. Given the rapid spread of the virus, social lockdown is urgent to bring overall transmission of COVID-19 down. It is important for us to understand that the economy can be revived after the pandemic, but we cannot revive the lives of people which are lost if they die because of COVID, and the responsibility will be on us. Thank you.
Thank you so much. Now we are done with the debate. I would request all the honorable judges to please submit their judgments so that their results can be compiled and announced in a short while. Meanwhile, I would request Professor Muhammad Waqar Azim, who is chairing today's final session, to please have his critique and comments. Please, sir.
Thank you so much, Danish. First of all, I'd like to thank you, my co-chair, Dr. Yusuf Haroon from Australia, all the judges, Dr. Majid Gondal, Dr. Muhammad Arshad Hussain from Australia, and Dr. Khyber Ashraf from Australia, Ms. Laila Amir Lalji from AKU, and Dr. Muhammad Zuman from UK. So very thankful to all the judges and my co-chair for attending this session. First of all, I think this was one of the most passionate debate I have ever heard, especially since we can't even see the debaters. Even just hearing the voices, I can't imagine how much passion they're putting and how much heart they're putting into it. I will congratulate both teams, Dubai Medical College, Fatma Mariam, Rehab Farooq, Alina Khiati, and Tarab Iqbal, and KEMU, Abdullah Said, Faiza Khan, Sarmad Arshad, and Abdullah Liaz. You both teams have done an amazing job in defending both sides. I think it's such a tough area to present because both things, both health and economy, are very important. I was especially moved by some of the comments both teams made. For example, from the Dubai side, they, in their opening remarks and their closing remarks, they have a lot of facts and numbers to support their argument. Giving examples of New Zealand, Switzerland was amazing. And I love the quote from Lena about Mahatma Gandhi. I think that was a wonderful quote to put together. From KEMU team, great opening remarks by Abdullah, talking about especially the impact on our common people, how it's impacting them. Then from Faiza, talking about unemployment numbers in millions. Then Sarmad and Abdullah talking about how much unemployment and hunger can play a big part. One thing I found striking, which I think is probably impacting the whole world, which also tells us how important it is that how we work together. So if you heard the debaters, all the debaters from Pakistan, they have some realities which are very particular to that country, whether it is related with health, whether it's related with economy, whether it's related with literacy, whether it's related with resources. Same goes for Dubai. It's very different how the things work in Dubai or UAE, whether it's related with health, resources, manpower, a lot of those things. So every country has a lot of different ways to do things. But globally, I think it's so important that we work hand in hand for all of us to work together to counteract this important task. But again, thank you so much, both teams. And I can't imagine, or I can't wait actually to see them in person or hear them in person in auditorium in Middle East or in Pakistan. Thank you so much. And I will ask Dr. Haroon, my co-chair, to give his comments. Thank you.
Thank you, Professor Azim. I think you have summarized very well, so I have not much to add on, I suppose, but I would say it was really a very passionate debate. In fact, a lot of learning for me sitting in Australia here, dealing with COVID firsthand. I suppose the COVID-19 impact on health is an imminent and present danger, of course, while the extent of impact on economy is still emerging and relatively unknown. So in a way, the arguments and the balance between the topics was very interesting. And I think both teams handled very well to bring their arguments. And I think one of the things which was raised from both sides was really the context and relevance is so much important to link with the evidence provided. Just very briefly highlighting some of the things from each team. From Dubai side, they provided a very good risk analysis right at the start of their debate. Rehab also did a quick environmental scan about the health issues as well as recent events. And I think overall, the quality of language and quality of presentation was very effective. As Waqar has already highlighted that, of course, we couldn't see you, but we could feel the passion in your arguments, in your presentation. Trab did excellent with rebuttals, and she provided a very calm approach and, in fact, took control of the arguments very well, as well as in the rapid fires section. I think there was good strategy to try to change the context and derail the opposition arguments. That was quite interesting and good to see the tussle between two sides in their arguments. And in the end, of course, Fatma concluded the arguments very well. Coming to Team A from King Edward, I think it's good to see that how they actually handled a very difficult topic to prove about something which is, of course, not so obvious than a health crisis. And I think at the start, Pfizer provided quite a few statistics to support the argument from their side. Sarmad also raised, interestingly, the mental health as an economic issue. And I think this can sometimes go on either side, but it was very good to raise that issue, I must say. And I think Abdullah also raised very good point about the context of New Zealand example and how that may be applied into the subcontinent or in case of Pakistan. And in the rapid fire section, I was really fascinated how while one team was trying to change the context and the other team, like in this case, Abdullah, how he regained the argument as well. And overall, in the final stage, Abdullah summarized arguments very well. So I think overall, it was a great debate and we all learned quite a bit from these young, fresh minds. Thank you very much.
Thank you so much, sir. Thank you. We are really honored and pleased to hear such kind words from both the chair and co-chair. Now I request Professor Muhammad Waqar Azim, please announce the results for today's debate. Sir, do you have the results?
Yes, so we have the results. I will say I personally don't see, I think I will probably speak for all the judges and panelists that there is any winners and losers. I think both teams have done an amazing job in presenting their point of views. And at the same time, we have to announce the winner. So with not much margin, actually, it's a close margin. Team B, Dubai Medical University, wins the competition.
Thank you.
I hope you can hear our claps from Australia.
Thank you so much.
Thank you to everyone.
Thank you so much for a lovely debate and a great experience.
Yeah, it was overall a very engaging experience for us and we thoroughly enjoyed this online debate. Thank you once again.
I'd like to thank everyone as well from APPNA for joining us here and obviously from the Bay Medical College as well. Congratulations on the win. It was a very good, interesting debate. I loved speaking I believe I speak on behalf of all the participants from King Edward that we absolutely loved speaking against you. Thank you so much. And
Thank
congratulations.
you. It was a very enjoyable thing for us as well. I think it was a real, it was a very emotional thing for in the beginning, and then we came to the saviors, this mental health, and now Corona. It has been an amazing day, and definitely we look forward to more of these.
Inshallah, we will surely look forward to more of these, and no doubt it was a very engaging contest.
So just brief remarks at the end, unless anyone else want to make any comments, I just want to make some closing remarks from APPNA Merit.
So please continue.
Okay. So first of all, Danish, you are pro. Looks like you're running the TV shows, how you moderated such a tough 3 debate session. So my hats off to you. You've done an amazing job.
Thank you so much, sir. Thank you so much.
So I'm especially thankful to Khyber Medical University, KEMU, and Dubai Medical College for participating or helping with these debates. Also like to thank Australian Association of Pakistani Professionals, APPNA, APPS, all our judges and panelists from all over the world, our nursing leadership, especially Professor Rafiq, Dr. Naeema Al-Gasseer from WHO. We are extremely thankful to all of you. And for APPNA Merit, I think soon we have some reports which we'll share, but we are putting a brochure together which will tell you much more details about APPNA Merit. But for our medical students, you are very important for vision and mission of APPNA Merit. And wherever you are, and you are the future. And we are here to support whatever it takes. And inshallah, in next debates, we are hoping to have many more colleges participating in these wonderful arguments, rebuttals. So thank you so much, everyone. Wish you all the very best. And happy Eid al-Adha.
Sir, one more request I would like to make in the end, sir, if you please allow me.
Sure.
Sir, I just wanted to say that, sir, the APPNA Merit and this organization is just doing such a wonderful job. But, sir, the dilemma of Pakistan is, if I talk specifically of the Khyber Medical College and University, like most of the students here, they are not even aware of this thing. And they have many issues when they are going abroad or for different projects and researches. So if you could, sir, as being the co-chair of the APPNA Merit, if you can just strengthen your activities and strengthen your social reach, not only in Punjab and big provinces, but backward provinces like Balochistan and KP. And we'd help you for that, and we'd just give our best for that. So we'd be really grateful. So that each and every medical student in Pakistan is on board with this wonderful organization.
Thank you for your remarks. Inshallah, we're doing the best. Actually, Khyber, we have a heavy presence in the ICU especially. So actually some of our North American physicians are running the ICUs at Khyber. And we are working very closely with Bolan Medical College in Quetta also. But I think we are not reaching the medical students. It's mostly at this point, the trainees and the higher staff, the faculty. But I think we will work with your faculty, inshallah, to reach the medical students more. I'm hoping we will discuss how to do that, but we will open any kind of suggestions, like should we create a separate wing for medical students for APPNA Merit or do something similar? So there can be a number of ways we can do that.
Yes, sir. Thank you so much, sir. One suggestion would be, if you could just in each university appoint an ambassador of APPNA Merit who can just convey all the things. So that would be a very beautiful or a very good thing. So if you can please think over that and then decide accordingly.
Excellent point. We will inshallah think about all these points and suggestions.
Thank you so much, sir.
Okay. Thank you so much. Wish you all the very best.
Thank you. Goodbye, everyone.
Bye.
Thank you.
Bye.
Thank you.